So very good evening, everyone. So please take your seat. So very good evening, everyone. So this time we are gathering here for I-5 symposia on the vaccination. And what is I-5? Basically, I-5 is a infection academy by the PACS. And in our previous session, we mainly focused on the treatment part of the various infectious diseases and the chronic respiratory diseases and how to choose the appropriate antibiotics in that particular scenario. This time we are more focusing on the preventive aspects of the various chronic pulmonary diseases and also all those patients who have various comorbid conditions like diabetes or cardiac comorbidities, chronic kidney disease, those who are on immunosuppressive therapies. So what is the role of adult immunization in those subset of patients and how to prevent the various infectious diseases in those subset of patients. So to enlighten us today, we have stalwarts of this field with us, not only the pulmonologist, but also the physicians with us to enlighten the various other aspects of the other vaccines which we are using apart from the chronic respiratory disease patients. So in the first session, we will discussing about the what are the various adult vaccines available in India and what are their significance, in what situation we have to use. In the second session, we will discuss about the practical challenges in the adult immunization and how to set up adult vaccine clinic. And in the third session, Dr. Kanishk will discuss the various case scenarios and the experts and the panelists will discuss those scenarios considering the clinical relevance. So before starting the proceedings, can you play the slides? So we made a questionnaire. So there is a panel of 10 questions and each one of you get the questionnaire on the table. So all of you should mark the appropriate answer as per of your choice. So the first question is, which of the following vaccination you advise frequently in your practice in chronic respiratory patients? So you can tick all which you are using: influenza, PCV13, PPSV23, the Tdap and the herpes zoster vaccine. Second question, which influenza vaccine you recommend in your practice? NH once a year, SH once a year, both vaccines every year, and I don't recommend influenza vaccination. So you can tick one or two, whatever which is appropriate and correct from your aspect. Third question is, when do you give influenza vaccine? In the month of April, May, in the month of September, October, anytime when patient comes and whenever patient agrees to take a flu shot. Fourth question is, which pneumococcal vaccine you prescribe in your practice? PCV13, PPSV23, both or none? Fifth question is, how you give a pneumococcal vaccine? PCV13 followed by PPSV23 after 2 to 6 months, PPSV23 followed by PCV13 after a year. Don't follow any schedule, and I don't know which one to give and why. Sixth question is, do you recommend the pertussis vaccination in a chronic respiratory patients? Yes, no, or I don't know about it. Seventh question is, do you give a herpes zoster vaccine to your patients? Yes, no. I advise, but they don't take it, and I don't advise, scared of the zoster vaccine. Eighth question is, do you check for the hepatitis vaccine status in your patients? Yes, no, only if they had CLD, or why should I check? So it's regarding the hepatitis B vaccine. The ninth question is, have you given influenza and pneumococcal vaccine concomitantly? Yes, no, sometimes, and only at the time of discharge. The last one is what is the major reason for low vaccination uptake by the patient? First is the cost. Second option is lack of awareness in the patients. Third option is the fear of side effects. Fourth option is efficacy. Fifth option is there is too busy to convince these patients. So with this background, we'll start today's talk, and I hope all these questions will be entertained in the all three sessions. And for the first session, we have a renowned moderator with us, Dr. Vipul Mishra. He is a senior consultant in the Pushpanjali Hospital, Agra. And sir, please. So sir, we'll start the proceedings. Thank you.
Good evening, everyone. The first two things I have to do is difficult. The first is to moderate a session, which is where the speakers are the likes of Dr. Talwar and Dr. Guleria. I don't think that's possible. You can't moderate teachers like. The second is to give an introduction, which also I think is impossible, to give an introduction of Dr. Guleria and Dr. Talwar, who have resumes of the size of pulmonology books, and even their synopsis of their resumes run into pages. So, but I can tell you what I have seen. What I have seen is that there was a time when pulmonology was, it functioned in the shadows of internal medicine, and these are two teachers who have brought out pulmonology from the shadows of internal medicine, have established pulmonology and achieved excellence. They have trained an army of pulmonologists. I know most of you fellows who are here are already students of Dr. Talwar and Dr. Guleria. So without any further delay, I will invite Dr. Guleria, sir, who will speak on adult vaccination and focus on shingles prevention. Thank you.
Thank you. Can I have a laptop here?
Before the session starts, I would like to invite the panelists for today's session. First, I invite Dr. Azmat Karim, who is a senior consultant in the Scots Heart Institute, a senior consultant in respiratory medicine. Our second panelist is Dr. Varun Vajpayee, who is a consultant pulmonologist in Metro Multispeciality Noida. The third is panelist is Dr. Vijay Rathi, who is associate professor in pulmonary medicine at Patel Chest Institute. I welcome all the panelists to have their chair, and we can start the session. Thank you.
Thank you. I'd like to thank the PACS team and Dr. Talwar for inviting me over, and the topic that I have to Thank you. Yes, go ahead. इसमें कर दो, ऐसे चल जाएगा। ठीक है, हो जाएगा। So thank you very much. I shall be talking on adult vaccination with focus on shingles prevention. Oh, sorry. So this is basically a session which is partly sponsored by GSK. I think इसमें तो आ नहीं रहा, so I'll just stand here because. So if you look at adult vaccination or vaccination in general, I think it's very important to understand that with the exception of safe water, no other modality, not even antibiotics, have had a major effect on mortality reduction as compared to vaccination. So the importance of vaccination can never be undermined because that has made a huge difference as far as overall mortality is concerned. It's also important to understand that vaccine preventable diseases kill much more adults than children every year. We talk a lot about vaccination as far as children is concerned, but if you look at the data, it kills more and more adults than children every year. And the burden of illness in hospitals is huge in terms of influenza-related admissions, hepatitis-related admissions, and more than 40,000 deaths per year occur because of vaccine preventable diseases. Therefore, it's very important for us to really understand the importance of vaccination in adults. Having all this data being there, still if you look at global data, vaccine coverage is very, very low, and this is sort of dismally low as far as the developing world is concerned. So like I said, immunization through vaccination is counted as a second only to supply of safe drinking water as one of the most effective disease preventing measures globally, annually preventing estimated 6 million deaths worldwide. So the number is huge, and that is why it's very important for us to focus on adult vaccination if you want to look at more and more of vaccine preventable diseases. If you look at Indian data and the overall prevalence and incidence of vaccine preventable disease in India, there is a huge burden of disease as far as vaccine preventable diseases are concerned, as far as India is concerned, and there is significant mortality and morbidity, whether it be influenza, whether it be pneumococcal disease, hepatitis, measles, rubella, or typhoid. All of them contribute significantly in terms of morbidity and mortality. And therefore, almost 95% of vaccine preventable disease associated deaths have been reported in adults in India with deaths due to infectious diseases. So it's a huge number, and unfortunately, almost 2/3 of Indian adults are even not aware of adult vaccination. So it means that we really have a lot to do in terms of promoting adult vaccination as far as our population is concerned. And with the increasing prevalence of non-communicable diseases, this burden is actually going to increase over a period of time. Why do we need to focus on adult vaccination? We all know that age-related immunosenescence reduces resistance to infection. The ability of childhood vaccination to offer long-term benefit tends to wane, and therefore it's not there. Chronic medical condition increases susceptibility to infection, and there is a changing disease epidemiology that we see regularly, and that also drives the need for adult vaccination. Now, vaccination is different from what we talk about medicines. Vaccinations prevent disease, so it's very important. This you're not treating a disease or preventing a disease. It's given in healthy subjects. That is why there is a lot of vaccine hesitancy, because a person feels he's healthy. If he takes this, he will get some side effects. It has to be given to a large number of individuals, and it acts both at an individual level, but it also gives herd immunity and therefore acts at a population level. And of course, you are looking at safety because side effects have to be minimal, and safety concerns are paramount because you're giving it to healthy individuals. And this is very different from what we would say as far as medicines are concerned, where you are willing to accept some degree of side effects. It's given to people who are sick rather than healthy, and therefore the whole paradigm is different as compared to medicines when it comes to vaccination. The other important thing to remember is that there has been a huge shift as far as the demographic is concerned, and that is why vaccination becomes important. If you look at data from, let's say from our independence, at independence, average life expectancy was around 30, 32 years. There's a whole shift as far as the demographic profile is concerned to a older population. And if you look at what is happening is that it's estimated that by 2050, 15.8% of Indians will be over 65 years of age, whereas just 5% will be under 5 years of age. So there was a whole focus on vaccination in young children and infants when the burden of disease was much high and we were trying to decrease infant mortality, decrease infection in children. But the whole burden of disease is now gradually shifting to the older age group. The demographic profile is shifting, and as the demographic profile shifts, there is also a huge need for us to really look at how does that really change our vaccination policy, and how can we now look at preventive health in terms of the changing demographic population structure that is happening in our country. So why to vaccinate? They're effective in preventing various infectious diseases, strengthen the immunity which decreases due to immunosenescence, and reduce the serious health complications, hospitalization, and even death, particularly for older patients. It helps to build herd immunity and therefore decreases the burden of disease and helps to reduce transmission of infectious diseases. So there are two situations. One is that you're not going to vaccinate the entire population. You will need to look at the most vulnerable groups to prevent in terms of vaccine preventable diseases. It could be the elderly, like I've already mentioned, individuals with comorbidities, it could be alcoholics, pregnant women, healthcare professionals, and people going to a large gathering. It could be Hajj, it could be the Kumbh Mela, where it's very important that you are able to prevent outbreak of a disease happening, which could be prevented by vaccinating the population. It's also important to remember that vaccines not only are able to prevent morbidity and mortality, they have other effects also. They have health effects like decreasing morbidity and mortality. It has an economic effect because it is cost saving, it's effective in sort of preventing outbreaks, and also it has a social impact because it leads to equity of healthcare and it helps to strengthen the social and the health infrastructure. So the first issue is to decide whom do we vaccinate. We don't, like I said, can't vaccinate the entire population. So you look at high-risk groups, the demographic of patients, the elderly, persons with chronic medical condition, immunocompromised patients, pregnant women and travelers, and then there are certain groups where you would also consider vaccination. It could be people living with occupational risk of infection, it could be workers working in old age home or people working in a health facility, healthcare workers, very, very important that they should be vaccinated, not only to protect themselves, but protect their patients, because if you have, let's say, flu, and you give it to your patients, then it's not an ethical thing to do, and therefore they should be vaccinated, and then of course various other groups need also to consider vaccination. So the high risk group become the older age group, immunocompromised patients, those with chronic illness, and those who are going to mass gatherings. These are the groups that one needs to focus on when one talks of adult immunization. So as we look at the changing demographic, that we are having more and more older population, it's also important to understand that as this demographic pattern has changed, there's also a change in the immunity that we have in terms of aging. So the immune system in newborns is immature, leaving them at a higher risk of infection, and that's why we think of vaccinating them. In the immune system through childhood and adult becomes relatively more robust, and therefore the issue of vaccination becomes a little less. But as we tend to age, there is a weakening of the immune system, the immunosenescence process, and therefore there is a higher chance of getting infections which can have a higher morbidity and mortality, and that is why it's more and more important for us to look at vaccinating the older age group. So as we age, there is issue of decrease as far as the hematopoietic stem cells are concerned. The NK cells also get altered. The inflammatory response is altered. There is an aging which occurs. Aging itself is considered an inflammatory process, and that itself leads to inflammation, which also changes the profile of many diseases. So you could have a higher exacerbation of underlying inflammatory disorders because of the aging process itself. There's alteration in the antigen presenting cells, the T cells and the B cells, and this whole process predisposes individuals to higher morbidity and mortality due to various vaccine preventable diseases. So if we look at the whole process, we're looking at an elderly group of patients who have underlying medical conditions, because as you age, you start having more and more comorbidities. You have inflammaging, that is, as you age, the inflammatory cytokines tend to increase in your body. The innate and the adaptive immune response gets altered. And along with that, individual response to pathogens is something that also gets altered in a manner that you respond differently to an infection, unlike what you would have done in a younger age group. All of this combined predisposes the older population to a more serious infection, and this leads to the reason why we need to aggressively push for adult immunization. So vaccination in adult individuals, basically because of immunosense, decline in innate and adaptive immune response is something we need to look at. You should target vaccines which are causing a higher chance of infection in them, and there are barriers which we will discuss subsequently, and therefore there are unmet needs. Second is, of course, the immunocompromised patients whose immune system is weakened because of various factors, and again there are barriers that we need to keep in mind and disease targets that we need to discuss. But as we start looking at this, then we have the whole concept of what is the life course immunization, which is considered as a gateway to health. That it's not only vaccinating the children or the younger age group and the elderly, it's vaccination throughout your life course, which is something that we need to look at. So vaccination at the younger age group when immunity is low, at the older age group when you have immunosenescence and you have more of comorbidities, but even during adult age, because of growing prevalence of comorbidities, pregnancy, working-related issues, and then of course outbreaks and endemic areas or travel-related issues that can happen. Therefore, you are looking at vaccination needs throughout a person's life. It could be infants and children, it could be adolescent and adults, it could be travelers, pregnant women and older adults. So when we start talking of vaccination, I think adult vaccination is now something which spans throughout an individual's life, starting from infancy to old age, and it's something that we should start promoting more and more aggressively. And there's a lot of data which suggests that this is also something which offers economic benefits to society. Often one has looked at a traditional view that wealth is needed to achieve health, and that is something which is very important, but it's very important that if you are able to vaccinate your population and you are able to develop a healthier, more productive aging population, and the adults are protected, it helps for economic growth and it becomes an economic driver. So it's not only the fact that you're trying to protect individuals, you're actually looking at better economic growth because you have people who, the workforce is not getting ill that frequently. So I'll just switch gears quickly and just quickly discuss a few vaccine preventable diseases which I think are important from respiratory point of view before I just then briefly discuss shingles. So I think one of the important issues is influenza or a flu, which is something which we must understand is very common in our country. I remember 25 years ago, if I would give a talk on influenza and talk of influenza vaccination, people would come up and tell me we are a tropical country, we don't have flu. Flu is only seen in colder areas like US or other areas. And it would be a tough time for me to convince them that we have flu in our own country. And it took a pandemic of the nature of H1N1 to really convince people that there is a huge burden of disease as far as flu is concerned. So even if you look at United States, where they have a robust flu shot program, almost 30 to 40,000 people die every year in the US because of flu. So it's not a mild illness that one can say happens only in colder areas. And there's a significant morbidity and mortality which is linked to flu. This is a paper published by Tim Yuki, who was in the CDC, and he tried to collect all the data that was available from Southeast Asia and trying to look at the burden of influenza. And he sort of calculated, based on whatever data that was available, that almost 11 to 26% outpatient febrile illness and what 6 to 14% of hospitalized pneumonia are due to laboratory confirmed influenza cases. And his argument was that influenza burden is expanding and substantially in Southeast Asia, and he felt that it is similar or maybe more than what we see in Europe and North America. So the burden of influenza is significant, and we behave in a different manner. We have these multiple peaks. We have monsoon peaks and the winter peaks, And you can see that there was virtually no influenza during COVID because it was overtaken by the COVID virus, the coronavirus. But throughout the year, we continue to have different subtypes, and we have peaks in the monsoon months and during the winter months. As a matter of fact, if you look at the flu network data, India, except for Srinagar, all other parts actually tend to follow the monsoon. And as the monsoon hits the Western Ghats, you have more flu there, and then in Chennai, it occurs much more later when you have the monsoon which is receding. So our data for flu is very different from what we see in other temperate areas. And flu vaccine, there is enough data to suggest that it has huge benefit in terms of the hospitalization, heart attacks, strokes, COPD, and decreasing the chance of acute infections. And I think that is something which we need to keep in mind, that there is enough data to suggest that this vaccine does help. And even in patients with chronic respiratory diseases, this helps to decrease the risk of complications, hospitalization, and risk of deaths really comes down. Moving on to pneumococcal disease, another issue where people said that, the data suggests that pneumococcal pneumonia is not fatal. You have to have invasive pneumococcal disease to really have high mortality. Pneumococcal pneumonia does not really cause that much of mortality, but there is data both from CMC and from other centers in our country which suggests that even in the elderly patients, mortality of as high as 26% can happen in patients with invasive pneumococcal disease, and it is not uncommon as far as India is concerned. This is a paper from CMC Vellore by the Incline group which looked at invasive pneumococcal disease, and this is from 7 tertiary care hospitals, 15-year follow-up. They had around 450 adult cases, and despite these patients being admitted in a tertiary care hospital, the mortality was almost 25 to 30%. So very high mortality being reported, and that is why it's important for us to focus also on pneumococcal prevention, because in the elderly age group or those who are at high risk, IPD, invasive pneumococcal disease, can have a very high morbidity and mortality. And therefore, there is data which suggests that pneumococcal disease in the elderly can lead to worsening of the underlying illness and high morbidity and mortality, whether it be COPD, diabetes, asthma, or a person who is actually smoking. Another very important thing to keep in mind. And if you look at invasive pneumococcal disease and you start looking at the case rates and the death rates, you'll start seeing that the death rates actually start rising as one goes into the older age group, and this is associated with significant mortality in the older age group. If you combine this with the comorbidities that these individuals have as they become older, then the burden of disease and the chances of mortality become even higher. Because as you start looking at an aging population and you start looking at increasing comorbidities, whether it be heart disease, chronic lung disease, alcohol abuse, as compared to healthy individuals, the number of cases of invasive pneumococcal tend to become significantly high. So an older age population, added comorbidities, leads to much higher chance of invasive pneumococcal disease, which has a morbidity or a mortality of almost 25%, and that's why it's very important for us to be very aggressive in treating this. So I think these are two very important diseases that we as physicians need to aggressively work on, trying to get our patients to get themselves vaccinated in terms of vaccine preventable diseases. I'll switch gears and quickly discuss about shingles, which maybe does not cause significant mortality but is associated with significant morbidity. It's basically the herpes zoster virus. We all know, if you look at individuals over the age of 50 years, it is present in almost 100% of the population, that they have the virus dormant. It stays latent in the sensory ganglion nerves and is there throughout life. Up to 1 in 3 people will develop shingles in their lifetime due to varicella zoster virus reactivation, and this can lead to significant morbidity in terms of the infection. It leads to acute pain, impairs their quality of life, and is seen much more in those individuals who are immunocompromised or in the elderly population. And therefore, it's very important for us to understand that in people who are at high risk, it can lead to increasing burden. And data suggests that the burden of disease in terms of herpes is actually increasing over a period of time. If you look at global data, it's estimated that 3 per 1,000 to 5 per 1,000 person years is the worldwide incidence. Some data from India suggests that if you look at individuals more than 50 years of age, it could be 15 to 81%, and post-herpetic neuralgia is seen in a large number of individuals ranging from 10 to 54%. But it's important to understand that there are multiple risk factors which can further elevate the risk of herpes zoster viral infection. It's not only age, but it's associated with stress, malignancies, autoimmune disease, post-surgery risk, the use of steroids, cardiovascular disease, and in our patients who have COPD, the risk also is there of developing herpes zoster, and that is why vaccinating becomes very, very important. So like I said, it leads to significant impairment in the quality of life. You have people who have sleep disturbance, there is physical function becomes less, general activities become less, and this impacts day-to-day action as far as the disease is concerned. So although it's considered to be something which causes a significant degree of dysfunction, in some cases it can cause significant impairment. It can lead to post-herpetic neuralgia, which can be very painful, last for months, and cause a lot of discomfort for patients. It can have significant eye involvement, which can lead to keratitis, scleritis, uveitis, and can lead to vision loss. It can have effects as far as the cerebrovascular system is concerned, leading to strokes, TIAs, and can at times be associated with neurological disorders like encephalitis, Guillain-Barré syndrome, and even meningitis. So it's important to remember that although it causes a lot of discomfort, there are a small minority of patients who can have significant degree of disability because of herpes infection. So it starts off with just an acute viral rash. If it's picked up in the early stage, antiviral treatments are effective. But once you reach the stage of post-herpetic neuralgia, then majority of patients are not really satisfied with the treatment because it causes significant discomfort. You land up giving them tricyclic antidepressants, topical agents, a lot of drugs, gabapentin and all are also given, but the satisfaction as far as patient is concerned continues to be less. Now there are two trials, and I'll just quickly mention them, the ZO 50 and the ZO 70, which looked at individuals over the age of 50 and over the age of 70, around 15,000 patients in both these trials. Both of them were published in the New England Journal of Medicine, which looked at the efficacy of the recombinant virus to see how effective it was in terms of it preventing discomfort and preventing the occurrence of herpes. The standard dose schedule was given. And when we look at the efficacy of the shingles virus, we find that it has an efficacy of over 90%, both in terms of individuals over the age of 50 years and 70 years. And there is now a long follow-up data also available. Post-herpetic neuralgia also was significantly less in preventing as far as the vaccine was concerned. And follow-up data initially of 6 years and then subsequently of almost 11 years showed efficacy ranging from 80 to almost 87%. So the vaccine is effective in the long run also and gives long-term protection in terms of shingles once this is taken. Even individuals with comorbidities, it is effective in terms of its efficacy, and you can look at that there's a large number of medical conditions where the vaccine has been administered in people with these comorbidities or medical conditions, and the efficacy has still been over 85 to 90%. So just to finish my talk, I'll just say that when we look at vaccines, it's very, very important for us to understand that when we want to push for adult vaccination, it's important that multiple stakeholders get involved. And that means the health authorities, us as health providers, advocacy groups, the pharmaceutical industries and patients, all of them need to be involved if we really want to have a robust adult vaccination program. The reason why everyone needs to be involved is that this is a huge task of getting people to start accepting vaccination. I, for one, felt that post-COVID, we would have a big uptake of adult vaccination. It seems not to have worked. It has had, I think, a little bit of a negative effect because vaccine hesitancy has actually tended to increase. And also, there is an issue that the pharmaceutical industry also needs to be actively involved. Just 2 days ago, I had a patient whose relative got COVID-19 infection, was admitted, and he wanted to get vaccinated, but the vaccine is not available because there's no uptake for it, and therefore the vaccine is actually not being manufactured. And he said, why can't I get the latest vaccine which covers the latest Omicron lineage strain? The current vaccine that we have covers the older strain. So vaccine has to also stay in touch with the virus as it evolves and be able to provide protection for new emerging strains. And unfortunately, we've not been able to do that as far as COVID-19 is concerned. In the US, you have a vaccine which provides protection against the Omicron strain, but again, unless there is a good uptake for that and demand is there, the supply will not happen as far as the industry is concerned. So I think it's very important for us to understand that vaccine is considered one of the most cost-effective health intervention, not only in children but in adults also, and we need to push for this very, very aggressively. Adult vaccination is now becoming a necessity because, like I mentioned, there's an epidemiological shift which is happening in our population. We are becoming an older population, and therefore it is very important for us to understand that as the demographic shift happens, the burden of diseases shift to this population, and we need to focus on preventive health more than what we were doing in the past. Aging, immunosenescence, and chronic and infectious diseases all are combining together to lead to a higher chance of these individuals getting vaccine preventable infection, and we need to work on that. Also, the burden of disease in our country has shifted. We have now a higher burden of disease, almost 55 to 60% of non-communicable diseases, and many of these non-communicable diseases combined with an aging population predisposes them to a higher chance of getting a lot of vaccine preventable infections or diseases, and we need to work on that. And therefore, finally, a successful strategy which involves all stakeholders needs to be developed. We have to improve adult immunization, as in the long run, this will definitely help to decrease morbidity and mortality. I think that is very, very important if we need to move forward. Thank you very much.
Thank you, sir, for a very crisp presentation where you very rightly said that the opportunities for vaccination has to be lifelong and not just limited to pediatric population. You also very clearly sent a message that we need to keep looking for opportunities to vaccinate people in the OPD, otherwise our vaccination programs will peter out. Even our vaccinations will fail to evolve to cover majority of our patients. I think we'll take the questions at the end of the session. What do you say, sir? I invite Dr. Talwar for the next session. He will be speaking on the current vaccination guidelines for respiratory patients. After this presentation, we'll have a discussion for this session and we'll have some question and answer sessions. Thank you.
Thank you, Vipul, and good evening, everyone. And when Randeep ended his lecture talking about COVID-19, it reminded me of times now. Every morning we used to watch him and see that what is he telling us new to do. I don't think so any household in this entire country does not know his name or doesn't recognize his face. He's putting the slide. I can tell you that if you are traveling with him, you will zip through the security, because all security people will just fall on his feet and tell him how his advice has saved his family members. He's such a known personality. And I was also thinking that, we don't talk about COVID-19 vaccine now. And very rightly, he said that it has left actually a little negative impact rather than putting a positive impact, because now the new vaccine adaptation has become less. So influenza is still acceptable, pneumonia is still acceptable, but going beyond that is like becoming a little tough for us. I'm seeing something else here. कुछ और आ रहा है इधर? इससे चलना है? नहीं, it's okay, fine. Okay. Right. So after recognizing the need for vaccination, I think the next question which comes to our mind is that whom are the group of people or the people who need to be vaccinated? So I think he very rightly said, I think everybody needs a vaccination, but maybe a different type of vaccination, because it's a practice which you need to evolve. So the latest guidelines in our country, which looked at adult vaccination, is from the API, Association of Physicians of India. And you can see that there are 12 international societies which pooled in their own brains to get into their particular field as to what kind of vaccine is required in their patients. And from the respiratory part, you can see that Indian Chest Society and I with Richa represented it, and we are also the part of these guidelines which looked after at the rate of what the chronic respiratory patients require, what kind of vaccines, why and when. So my job is very simple. I am just going to focus on a couple of these vaccines. I'm not going to talk about respiratory syncytial virus and COVID-19 because we do not have them, but I'll be focusing on the first 4 of them. And we all know that they have been shown to improve the quality of life, that is the morbidity, and to some extent even a mortality. I know that data has been, very variable, and sometimes, there is a conflict also in the data. But I think most important thing is the crux that if it saves lives, if it saves trouble to the patient, then why not? I think that's a very important thing we must all remember. So this is the influenza vaccination which is recommended schedule by the API for patients of heart and lung disease, so predominantly heart-lung disease and all others. So you can see influenza 1 dose annually. Then we have also Tdap, which is again 1 every 10 years. Pneumococcal, PCV13 followed by PPSV23 1 year later. And then a booster of PPSV23 5 years after the complete vaccination given. They also talk about COVID-19 and MMR, but primarily these are the vaccines which are recommended here. So when we talk about influenza vaccine, I think the important thing which Randeep made very clearly is, apart from Srinagar, rest entire country, whether I am sitting in south or north, it won't make any difference because the vaccine time is according to the monsoon time, and we all need to be vaccinated in April, May to be ready for the monsoon season to come. So you can see that Srinagar, Chennai and Vellore are the only 3 places where you need to get the vaccine in September, October. So we need to vaccinate our patients with basically the southern hemisphere vaccine in the month of April and May. The only contraindication is if the patient had a very severe reaction, which is I haven't seen so far. And of course, the vaccine is recommended annually to all the patients. Then we have a pneumococcal vaccine, and as we said that we give initially PCV13 and then followed by PPSV23 1 year later. And if the patient is at high risk, then you actually fast track the vaccine, which is PPSV23 to 2 months after giving PCV13. But if you have already given PPS23, then obviously you can recommend after 1 year of that vaccine. So now there are new PCV vaccines going to come, and we know that there are 20, 21, 23, 25, 30, God knows so many of them which are trying to have, lots of strains to cover largely more and more pneumococcal pneumonia. And right now they are also recommended, but at the moment we have only 13, but I think we will be getting the 21 also very soon. And it is recommended in our GOLD guidelines that our COPD patients need to be given the pneumonia vaccination. And when you give pneumonia vaccine, it means you need to give both of them. Then comes pertussis vaccine. So this has come in the last two years or so in COPD because pertussis infections is causing COPD exacerbations, a lot of suffering, and as well as hospitalizations. And vaccine immunity lasts not much, and especially in elderly people, those who do not remember whether they were even ever given a pertussis vaccine or not, they need all to be given above the age of 65 years with the pertussis vaccine. So it comes with a tetanus and diphtheria. So TDP vaccine, there is some fire out here. Yeah, either. There is some short circuit which has happened. Somebody should please look into it so that I don't fire. There is something here. Short circuit in the board, I suppose. Anyways. So it is recommended for patients who are having COPD and above the age of 50 years and to give them every 10 years. So every 10 year, pertussis vaccine is to be given. That is Tdap, which is available in our country. So both are recommended. DTaP as well as DTaP-A, both of them are there, but we have this one available. Then in shingles. Now, I think Randeep said, it gives a lot of trouble and other things. I myself have suffered, so I know how much trouble it gives. But the important thing which I have observed in the last 2 years is our patients of interstitial lung diseases who are on immunosuppressives, they develop herpes zoster, and then it quickly becomes disseminated herpes everywhere. And then we lose them actually. They develop respiratory failure, and it's very, very difficult to treat them. And I do remember a couple of them we have lost with herpes zoster becoming disseminated herpes because they were on MMF or methotrexate along with steroids and managed the immunosuppression with this kind of a disease and underlying ILD, it becomes impossible to treat. So I think that's one thing which I always keep in my mind, that I need to give them vaccine, and preferably before you start with the immunosuppression. But if your patient is already on immunosuppressives, we give them whatever time they come to. So the vaccine is not only to give to the particular patient. I think this is the last slide, which tries to tell you to improve the herd immunity. So if you have said, I think you must have heard Randeep telling about it, that if 70% of the people are immunized, then practically you have reached the level where the transmission of the disease is going to go down. So herd immunity needs to be created, and that also needs to be kept in mind, especially our patients are mingling with every other person in the family. So there are big families where they get exposed to whatever happens to the rest of them. So with that, I will leave this, that these are the important vaccines which we use. There are other vaccines which we are going to discuss later on, and I will request Vipul to carry on with the panel discussions and take questions now.
क्या हो गया करंट भी मार रहा है सब कुछ अभी हो रहा है Thank you, sir, for a flurry of information and very crisp presentation. What I will do is I have a few questions which I will address to the panelists, and once they have expressed their views, those comments will be open to our expert speakers and we can have a discussion. So the first question is to Dr. Azmat Karim. The question is that which patients need which vaccine? Now, there are two kinds of patient population that we have. One is the healthy population, and the second is the patients who are suffering from diseases. So in short, what I would like you to express your views in what are the kind of vaccines which are required for healthy versus patients who suffer from chronic lung diseases.
So as we have listened, Dr. Guleria have mentioned very clearly that the people who is suffering from respiratory diseases and any chronic illness like cardiovascular, renal, CLD, and the immunocompromised patients and their caregivers. And in Delhi, in India, we are staying with the PM 2.5 and PM 10. So the people is also evolving with the respiratory diseases, and the respiratory disease means the airway is only a highway to give the complication of the other diseases. So I see there is no population left should not be vaccinated, particularly in the adult. Whether he's chronic or is going to be a chronic patient, we don't have any data that will tell us we have a healthy population at large, or these are the population who is healthy, and we have not a guideline of the health or basic health infrastructure that we will know. Maybe we are considering the people who is healthy, they are not. Okay, they're suddenly coming with the acute renal failure or the uncontrolled diabetes. So according to, in my practice, I have seen the people I have vaccinated few years back, they're coming with their family members, they should be also vaccinated because I'm getting well, I'm not getting hospitalized, I don't have symptoms. So they are asking ahead of the vaccination comes in the September, October. So according to me, everybody should be vaccinated, whether it's a caregiver or the family who is suffering from, or the patient who is having the people with the chronic ailment of any kind.
So, sir, do you think that is a valid point that he has raised about air pollution? Do you think that because the guidelines don't mention that you can modify your practices for vaccination based on the air pollution, what do you think about, do we need to add that as well because of NCR suffers from chronic air pollution and we need to broaden our...
So it's a difficult question because I think there is data that air pollution leads to airway inflammation and predisposes to a lot of, let's say, worsening of a lot of health conditions. But whether it leads to a higher chance of diseases which could be prevented by vaccine is something that one needs more data on. But I think I would tend to agree that there are certain, so let's look at it from a different point of view. There's no doubt that among people with chronic diseases, you should vaccinate. Also the elderly. So when you talk of healthy, if you have a healthy person who's elderly, he should also be vaccinated because of immunosenescence and various other factors. Now, if you look at the younger age group, who are otherwise healthy, then the issue is that we talk of life cycle immunization. If you look at recommendations in the US recommendation is that all adults should be vaccinated with influenza. So there is a recommendation already from CDC and others that you should give influenza vaccine to the entire population. The issue becomes what is practical and how do you prioritize things, and also what can you deliver. So it would be something that you need to keep in mind in the healthy population. We are a very large country, and if I say that the government should come out with a policy that everyone should get the flu shot, I think the budget itself would be very high and it would not be practical.
It will need an exercise as big as COVID.
Yes, so you will have to develop a strategy
everyone.
where you prioritize things so that it can be done. From that point of view, you need to see what are those which is easy to vaccinate and which need to be done. So pregnant women are one healthy group who one should definitely look at vaccination. We know that there is data for H1N1 which shows that they are the highest risk, and vaccination gives a triple benefit. It protects the mother, it protects the fetus, and it also gives 6 months immunity to the newborn when you have no vaccine. So there are 3 benefits of giving the flu shot to the mother during pregnancy. And therefore, there are groups which you should focus on. But in an ideal situation, one would like to vaccinate a larger population, but it may not be practical as of now.
So in the end, I think the take home can be, we can use physician discretion to immunize patients who fall beyond the guidelines.
Correct. So some patients come to you and they don't fit into the classical criteria, but say, can I take the flu shot? And you tell them, yes, you can take it, it will help you, you will be better, but it's something which is not as part of, I would say, the guidelines which have come out.
Thank you, sir. So the next question is to...
Vipul, the sad part of the story is that the allocated influenza vaccine to our country, a lot of it is to be actually thrown because it's not used. It expires. So there are countries who are struggling to get vaccine, and our quota we are not able to finish because of the reasons. We know that it's expensive and things like that. Everybody doesn't want. But I'm happy that at least Gold spoke about this, that air pollution and climate changes are making things worse for people. And the only answer which they have given for that is that you try to improve your air pollution and try to have healthy habits and try to take vaccinations. So I think that makes a sense that you said air pollution in Delhi.
Every morning we wake up, we see Delhi's AQI, and then we see, and people are buying expensive air purifiers. So if they're buying expensive air purifiers, why not give vaccine? Is the flu shot. Thank you, sir. So the next question is Dr. Varun. This is about pneumococcal vaccination. I think the penetration of pneumococcal vaccine is even lesser than the penetration of influenza vaccine, and then there's a lot of confusion about 13 and 23, which to give when, how much difference. Some of it has been recently been simplified by recent guidelines. So what is your take on how to, a message about how to simplify pneumococcal vaccine?
So currently we are giving two types of vaccines, this is PCV13 and PPSV23. In immunocompetent patients with chronic diseases like chronic lung disease, chronic heart disease or chronic liver disease, and with current smoker and history of alcohol intake, we are advising PCV13 followed by after 8 weeks PPSV23. And in immunocompromised patients like HIV, CKD, and any hematological malignancy, same doses, PCV13 followed by PPSV23 after 8 weeks of PCV13. And also in history of invasive pneumococcal pneumonia, we are prescribing same regime. And after more than 65 years age, prescribing PPSV23. And in immunocompromised patients, we are prescribing both PCV13 followed by PPSV23.
Dr. Talwar sir, I would like to ask how important do you think is this pneumococcal vaccine? We talk about influenza a lot, a little less about the pneumococcal. And what ACIP guidelines said that you should not give a difference of around a year between 13 and 23. And if you look at the information, I think the 13 gives is a much better vaccine for people to prevent against pneumonia than maybe 23. So what do you think?
I think, Vipul, this controversy of 13 versus 23, I will leave to Ram to address because they are very experts on this. And they have dissected the all information about it that, which one is better or not. And then they are increasing their conjugate vaccines numbers so that they include more and more. So we are going to get better vaccines. But yes, right now when the question comes to give both, at least all our chronic respiratory patients, immunosuppressed patients, patients who are on steroids, patients who are having a severe respiratory illnesses, we give both of them. Both the vaccines.
But you start with 13.
Start with 13 now. Previously, we were giving PPSV 23. But now the guidelines are more clear. If you look at the guidelines which were made in 2019, I think Randeep was a part of that. It was not so clearly mentioned at that point of time because data was not that this thing. But every time, we get stuck at the data basically.
I think it's important to understand how it has evolved also. We had a PCV7 also which came up in the early 2000, which was given to children, and it even showed that if you vaccinate your children, you can also protect the adults, because very often children bring the infection home and then the elderly get it from the children when they bring the infection home. But what it also showed was that the serotypes which are not covered by the vaccine, gradually they started becoming more prevalent and started causing more pneumococcal disease. That's why we are moving from different subsets of conjugate vaccine to cover more and more of the serotypes which are not getting covered and which therefore tend to emerge and become more dominant when you are able to suppress the other serotypes.
So
that's why we're moving on to others. And that is why giving both is important, because you're covering then a larger number of serotypes by giving both PCV13 and the polysaccharide 23.
And you think the newer vaccines will solve this problem, sir?
To some extent, yes. You are now among the most virulent serotypes you're covering, I think more than 80 to 90% of the most virulent serotypes, so that should help to solve.
Thank you, sir. So next question is Dr. Karim again. There's a lot of confusion about chickenpox vaccine versus shingles vaccine, on why we have shingles when we already have chickenpox. So can you elucidate on that?
So it's a two different disease at two different times by the same pathogens, that is varicella zosters. Chickenpox is occurring in the children's age group, and when they recover, the virus remains in the dormant phase of the body, and when body you evolve at the adult age or the middle age group, when these get reactivated, you have shingles. So the symptoms are almost same, but in chickenpox, the vesicles are all across the body, but in the shingles, you have the localized, tough, thick vesicles, and it is more neuralgic and painful than in the children. So it's clear that the virus is the same, but the disease, chickenpox and shingles occurs at two different stages of life.
Next question is also on shingles, after which I will take expert comments. This is to Dr. Varun. What do you think should be the current practice? Because I think the penetration of shingles, in spite of so much, hullabaloo about it, has been really, especially in non-metro cities, has been really very poor. There are a lot of talk about shingles, but very few patients actually end up getting it. So what do you think is the place of shingles in current pulmonary practice, and what do you think are the barriers that
So our patients now are increasing of shingles, especially the chronic patients, the estimating COPD patients, which have frequent exacerbations, receives oral steroids or IV steroids, and also in ILD patients which are receiving MMF or other immunosuppressants like azathioprine and methotrexate. So we have started advising Shingrix vaccine, but main problem is regarding cost only, that patients are telling about the cost. They are refusing for the vaccine.
The cost, yes.
Yes, sir.
So at the current cost, sir, I will take opinion of both the experts. What do you think, because we already now know that it is an important vaccine, it can prevent a lot of morbidity and a lot of mortality, as sir pointed out, in patients who are immunosuppressed, and more and more of our patients are getting immunosuppressed because of the severity of illness of pulmonary disease. So how do you think we should get around it, and what would be the right time to vaccinate with shingles?
So the recommendations are that everyone over the age of 50 should be vaccinated. Even if you've had shingles in the past, you should get yourself vaccinated again, because the chances of recurrence, the virus never goes away in terms of staying dormant. The issue of cost is something which one needs to really talk about. I think if you increase the numbers, if you have more uptake, the cost will tend to come down. So it's basically trying to see that can we have more awareness and more people come up, and therefore if the number of people getting themselves to take the vaccine increases, it will be cost effective for the manufacturers to bring down the cost. There could also be a mechanism that some of the cost is borne by, let's say, subsidized by some sort of benefits being given by the government. That could also help. But I think the important issue is for people to understand the importance of taking the vaccine. See, very often, a lot of patients have that thought process that shingles is not something which kills. Therefore, should I really bother about this vaccine? It's just causing discomfort. But the degree of discomfort that it causes, and the morbidity that it is associated with, and the fact that sometimes it can be very serious if you're immunocompromised, is something that you have to explain to the patient to get them to take the vaccine. If you just tell them that it is something which will just cause a little bit of a rash and pain, they would not want to spend that much for the vaccine.
So what stage of pulmonary disease you think we should, give vaccine? Should we give first shingles to every patient who has any kind of pulmonary disease? Is that the guideline? And second, at what time would you, ask the patient to really try to convince him about getting this vaccine?
So patients who are immunosuppressed because of taking immunosuppressive drugs, could be steroids, it could be immunomodulators, or who are on, those who are over the age of 50, I think you would definitely want to ask them to take the vaccine before you start all these medications, because once the immunity wanes, then the chances of reactivation of the infection becomes higher.
So, Dr. Valsa, would you think that we should start advising patients about Shingrix in almost all patients who come to our OPD, because all of them have some kind of pulmonary disease?
I think, in a private, things might look little different because they are ready to pay. And in fact, I do not know how Vidishi would be managing it, especially when you tell anybody to take a vaccine like 9,000 rupees or 10,000 rupees and you have to take 2 of them. So I do not know how. Actually, I would like to listen to you because now we are talking about private. What happens in government? You see a lot of same immunosuppressive patients, ILD patients, elderly patients, COPD patients. How manage in the government setups is the important thing.
Sir, so till recently, Shingrix was not available. So we have a very short period of experience with this. And the cost is prohibitive in government setup. But we have to explain to the patient the possible cost of a shingles appearance. So once you have a herpes zoster infection, the kind of morbidity it carries, 1 year of debilitating pain which might require him or her to visit a practitioner, to maybe visit a pain clinic, maybe end up with a disability for life that he has to consider, and the cost added because of that, the NSAIDs. Maybe the patient has CKD, the patient would require NSAIDs for pain. What would they do? They can't take those NSAIDs so much. So these kind of things, when you explain to the patient, over time, first visit the patient comes, you tell them you need to take this 9,000 vaccine, repeated twice, they would not take. Maybe later on, gradually, it would build up. So at the age of 50, 55, maybe we can start promoting, and maybe by 60, they might consider taking it. But the problem occurs that as the age increases, the efficacy of the vaccine might come down slightly. The good thing about recombinant vaccine with shingles, which had come, that even at more than 70 years of age, the efficacy is quite well, and it is not decreasing much with over time.
11 years was the data
Yes.
was 11 years.
The previous live attenuated vaccines which were available outside, their efficacy was around 50% for shingles prevention. So it was not a good thing. Here it is more than 90%. So I think we need to convince our patients. But for government setup, yes, the cost will have to come down before we can replicate on a mass level.
Yeah, I think
She has
so.
given such a good point that in CKD patients, we can actually convince them easily that can't give you painkillers, you might as well take the vaccine, because everybody knows that it's a painful condition. Everybody knows it's a painful condition.
I think in chronic lung disease, I think these patients are already spending money on their chronic condition, and then maybe it's easier to convince them
So
about.
the most important group which we had were lung cancer patients. In lung cancer every 2 to 3 clinics, we used to see somebody coming up with herpes zoster. They are already paying for lung cancer medication, and because of so much pain and with chemotherapy, they are the easier ones to convince though.
Do you think socioeconomic status also, has an effect on the frequency of shingles? Because I have seen people who have lower socioeconomic status suffer more from this problem, and they are the ones who can least afford this vaccine.
It's a little difficult to comment on that because we do not have clear data, but there has been some data worldwide that there is probably an endogenous and an exogenous protection against zoster. So there is some mathematical model prediction that said that because world over varicella vaccination has improved, and that is why zoster has increased, because the exogenous infection has reduced. So people used to get lifelong immunity because of that circulating virus that has come down. But that was mathematical predictions. And overall, there is some data that probably lifelong vaccination with varicella may eventually lead to a decrease in zoster development. So varicella has not been vaccinated for a long time, but it has been seen in children that those who had varicella vaccination, their zoster infection, zoster can occur in children also, the reactivation, their zoster occurrence is much less than those who were not vaccinated. So maybe we would have some future data about that.
If there's time, last 2 questions. This is about approach to patients. The first question is to Dr. Vidushi. If you have a 30-year-old patient come to your clinic, how would you, try to find out opportunities for vaccination? And the second question goes to Dr. Karim. If the same patient is of 55 years, how would you approach?
So in a 30-year-old, if you're talking about a healthy patient,
Anything. The
Okay.
question was actually normal. I've extended it to anything.
so if you're talking about a healthy patient in a 30-year-old, so the peak of his immunity prime, I would say that we need to first ask about the previous vaccination history. So if a person who has been never vaccinated, a healthy year-old comes to me just because he has heard about vaccination, I would probably ask about the previous vaccination. If he has not been vaccinated for DPT in life, I would go for that. MMR, varicella, if he has not had the infection and not been vaccinated, I would still go for that. Influenza, I would consider only on a case-to-case basis, because per se, sir, vaccinating everybody, like as sir had said, in a large population-based country like India, if you vaccinate everybody, there's something called as overdoing something, and we would have more side effects in general because of the large population. With COVID, everybody became scared because of the few side effects reported, and we have to be considerate of the fact that the benefit versus side effect ratio has to be managed. And influenza efficacy is very low, even for severe disease. It's around 50%. So you tell them that you take this vaccine and you would not develop any flu-like illness, that becomes a problem. Influenza efficacy is good for H1N1, it is not good, that good for H3N2. So all those things have to be taken into consideration. But yes, if a person has a young infant at home, elderly caregiver, elderly patients, or they are people like us in hospitals taking care of immunocompromised, then give them the influenza vaccine. Consider for that.
What about tetanus toxoid and diphtheria?
So tetanus again, sir, diphtheria is actually advised every 10 years. I have never seen anybody getting it, even among the medical fraternity, taking it every 10 years. So you get
I think
hit.
tetanus toxoid has died on the burden of COVID-19 and influenza, because I remember in our teenage days we used to very strongly prescribe in our MBBS days everybody to take tetanus
Yes,
toxoid.
so
I think we've just forgotten about tetanus
So
being
till
a being
internship, everybody received tetanus, and after that, nobody received unless they get hit. So tetanus, yes, and now tetanus is being shifted to TD, so that
Yes.
is good. Pertussis, additional, the good thing about India is we had a wholesale pertussis program as opposed to Western countries, and wholesale does have a longer lasting immunity as compared to acellular pertussis. Now, whether that was pharma driven or whatever, everybody shifted to acellular, but India, we still have a better immunity probably because of the wholesale pertussis.
So we don't need pertussis vaccine. TND is the one which we need to have.
Probably.
Dr. Karim, what about
So as
55
per the
years? How would that
guidelines, I
change?
will recommend the vaccinations. Whatever vaccine is pending with him, or based on the clinical conditions, I will recommend the vaccination for the 50 plus patients.
I think we have another session on non-respiratory vaccines. We'll talk about that later. But I will also now invite questions from the audience to panelists or to our, and if there are any questions, we can take them now on the current two topics that we have discussed. Anyone? Yeah, please.
Sir, I have a question to Randeep, sir. Yeah, regarding the herpes zoster vaccine. So basically there are two diseases, zoster and varicella. But there's immunological basis for different vaccines for same virus. What is the rationale of two different vaccines against same virus?
So one is an infection which happens, the other is a dormant infection getting reactivated and therefore causing more of a localized disease as compared to what happens in children, where it is a more of a disseminated disease and therefore it's a different behavior of the virus, and that is why the vaccine tends to be different.
Okay, thanks, sir.
Any other questions?
I think one thing is, like she said about influenza, can't be given to anybody. But I think I will definitely still consider that we as a medical community who looks after these patients get exposed maximally to that. And you would remember that 2008 onwards, we have been vaccinating to the entire staff as soon as the vaccine arrives. And we have been able to work for years without getting, except this year when I think everybody got sick. I do not know whether it did not cover the strain or was it not only influenza, it was something else. But it really made our life more comfortable in looking after these patients, because there were spates of them coming, and we started vaccinating everybody, all nurses, doctors, young, old, everybody actually used to get
It
it.
gives them a level of confidence, especially to the nurses who become afraid
yeah.
whenever there is an H1N1.
It's very important to push for healthcare workers to get vaccinated. And when one pushes for it, I remember one of the senior residents once when we were getting it done in a ward telling me that I'm sure I've got influenza in the past, so I should not get myself vaccinated. That logic doesn't work. That if you've got it in the past, but the efficacy of the vaccine will vary from year to year, because the virus will have some degree of an antigenic drift. And if that antigenic drift will vary between the time that WHO gives the strain and by the time it comes out into the market, if that drift has happened, the efficacy of the vaccine will tend to fall, and therefore then you have that
So
problem.
I think our so-called completely healthy population percentage is also coming down. Everybody has some kind of problem or the other. So I think we have get more and more opportunities of
unhealthy.
vaccination. With that, I call to end this session. Thank you, panelists, and thank you, Dr. Alvar sir and Dr. Guleria sir.
New obesity guideline, I think all of us will come into obesity.
Now I invite Dr. Deepak to carry this forward.
Thank you, sir. And thank you all the experts and the panelists. And special thanks to our moderator who moderated this session so well. So I would request Dr. Vipul to please be on the stage because we have to felicitate you with the memento. I request Professor Guleria sir to give the memento to Dr. Vipul. So I think we'll do the photo ceremony after this session. So for the next session, I would like to invite Dr. Bharat Gopal. Dr. Bharat Gopal is a director and head at the Delhi Heart and Lung Institute, New Delhi. And he is having a very vast experience in the field of pulmonology. Dr. Bharat. Sir.
So till they, will this work? This one? So you know the problem of electric personalities taking the dais before me, it creates a short circuit. So that was the reason, Dr. Talwar, you and Dr. Guleria on the same dais, it's too hot to handle. So how many of you are actually vaccinated apart from the Jabardasti vaccines of COVID? How many of you of flu? Good. Pneumococcal goes down. Anything else? Hep, I'm not talking about Hep B. So shingles, 2. So we're going down. So that's actually so probably you are never too old. So I think with that we begin the problems which we are facing, why these guidelines and all the things we discussed over the last 1.5 hours still unfortunately has not led to, and believe me, we have been discussing things for some time. It's just that we are adding on to the list of vaccines, we are adding more data that the efficacy and the need, but we still stand where we were probably 10, 12 years back. And I agree 100% that even I expected that after the COVID vaccine, probably people would be less scared and the hesitancy would have probably gone down, but unfortunately it has not. So we have seen the vaccine preventable diseases, huge burden and unfortunate burden because they are all preventable. This is a small study because I just wanted to put the next 2 talks into perspective, that those who probably should have warranted vaccination, only 38% were counseled at the given opportunity. So I think therein lies the problem from our side. I'm not talking of pulmonology, infection disease, but for a basic physician, there is an opportunity to probably talk to the patient for various other aspects rather than what he has come with. And vaccination is one of them, right? We may be talking about diet, weight and all that. I think 2 big things which respiratory physicians are worried about, a lot of us actually miss. It's smoking and vaccination. The chance to actually dwell into them, that these are 2 very, very probably modifiable risk factors for their patients, I think it's a tough thing. So we've all seen these thing in the previous slides, that if you look at the things across the board, the chances of patients actually dying from invasive pneumococcal diseases and meningitis is huge. And we know the reasons now. I think a lot has been said. So with that, I think I'll invite the first speaker. And if I can have my both panelists on the stage, Dr. Siddharth Yadav and Dr. Sandhya Nair. And it's your wish to
sit there, as Vipul made everybody sit on the stage, or you can go down and listen. Please come and join us for a short while. And may I invite our first speaker, Dr. Madhumita Ram, Senior Consultant in Infectious Diseases and Infection Control, all the way from MGM Chennai, an accomplished researcher. It's very nice to have an ID person with us. I think a specialty which is not taken up a lot in Delhi NCR as of now. Very few people are here. So ma'am, all yours, and she will be speaking on practical challenges in adult immunization. Let me see how it put your, can you have her slide set?
Okay, when I come on the stage, there are always some glitches. Anyway, till they set up the slides, thanks to the organizers for this invite this evening. After two eminent speakers and a lot about vaccines, I think mine would be just a post-test questionnaire. And with the permission of my moderator, I'm going to make it interactive. Otherwise, it would be just theory. And so, my panelists, there would be some questions directed to you regarding your practices. And with my small practice, which we set up way back in Apollo, and how successful we were in setting up an adult immunization clinic, maybe some practical insights into it would be my discussion today. So if I can, yeah. So I requested them to give me access over here, but then I still have to use this. So how do I move it? This way? Okay. I think Dr. Bharat already asked the question, how many of you had taken the vaccine? And I think influenza most of us have taken, and there aren't a very old group here who would require pneumococcal or Shingrix vaccine. Most of us are very young, but we've taken that. But when, mostly when I start a presentation, most of them wouldn't have taken a vaccine, and this would be my face. But I can't go home. My flight is for tomorrow, so you have to, for the next 20 to 30 minutes, you will be listening to me. So going with the first scenario, I think we discussed about this quite a lot, but let me ask again. A 55-year-old diabetic patient refuses to take the influenza vaccine. To my panelists, what do you think is the commonest reason for refusal of vaccine?
The first reason is the cost.
Okay.
Second, efficacy. Like they expect that if I get the vaccine, then I should not have the disease altogether. So to explain them that it is just to reduce the risk of the severity of the disease or to reduce the risk of transmission, people are not very convinced with it. And especially if they have already taken a vaccine, they have I took a vaccine, still I got flu, so it's not useful to me. That's the most common one.
Excellent. So that's a difficult question to answer when somebody comes up with it. And that's what we call as vaccine hesitancy. And how do we go about this? We all know about vaccine hesitancy. What would you do to counter this misinformation or their belief?
For this, actually, we need a full program. Ideally, we should cater these patients separately, and we should give them awareness orientation that why is it necessary for you? How is it going to help you further? It's going to decrease your morbidity, it's going to decrease your mortality, and moreover, hospitalization rates and the other issues, comorbidities would be controlled. So that needs to be told.
Excellent. So the role of healthcare persons in educating the patient. So if you look at the vaccination, continuum of vaccine acceptance, you will see a set of people who would just listen to anything and everything that you say. No questions asked. You ask them to take a vaccine, they would take. There is a set of people who would outright refuse you. No, I'm not going to take any jab. I don't want a vaccine. But there is a middle population which wants to take but doesn't want to take and has got multiple reasons for it. Maybe because of the cost, maybe because it is painful, or maybe like the doctor said that, I still got influenza despite taking the vaccine. And this study is not about a common person. This is about healthcare workers refusing vaccines. And if you look into the healthcare population, the most commonest reason for not taking a vaccine is, I don't need it. Second is, I might experience side effects, so why take it? And I don't think the vaccination is effective in preventing, and I have to keep repeating it. What is the point of taking? And these were published in the newspaper. This is about the general public. The general public feels that adults don't need the vaccines because they are not at risk of falling ill. And another commonest reason is, the natural immunity is much better than the vaccine-induced immunity. So I might as well get an infection. So this is what everyone believes, and probably that's the most commonest cause for vaccine hesitancy. And how do we tackle it? If you go and tell them, no, vaccines are good for you, it comes back to you. With a simple example, COVID vaccine. So never force a vaccine in somebody who's refusing a vaccine. But how do I go about it? I talk about the disease. As ma'am said, I talk about how, if you fall ill, how much you spent in the hospital. Probably it would be much more than what a vaccine would have costed you. Communication. How do I communicate to the patient? Sometimes you don't give them a choice. You just have to say, you have to take it. Like, are we given a choice in pediatric immunization? It's nothing. 6 months, you have to take this vaccine. In 4 weeks, you have to take this vaccine. That's it. So you don't give them a choice that, would you like to take it? You just say, it is recommended and you have to take it. Or probably, talk to them and find out. This talking and finding out, how we did at 10 years back when I was with Apollo, when we wanted to set up a vaccine clinic, I was still a student. I had to do rounds, but then there was a time between 11 o'clock to 1 o'clock that I had to sit in the MHC and just talk to the patients that there are vaccines. Preventive health is not just about doing blood tests today, which just says at this point you're doing well. What is that you've invested in keeping yourself well in the next 1 year or next 2 years? So that is where, you need to talk to them and find out their reason for not taking and motivate them to take. And I think we've gone through these slides. There are a lot of benefits of vaccines. Probably if we could put these kind of standees, or in our TV screens, we put advertisements saying that why vaccines are needed. Maybe many more of our patients would take vaccine. And have you ever wondered who influences adults to take vaccine? Maybe Modi ji, because that's when all of us took the COVID vaccine. Or the dream girl, Hema Malini, I think many would have taken. I come from South India, maybe because of Rajinikanth I took it. Or many of my patients took it because of me. And if you look into this study, it said that you physicians are the ones who influence your patients to take vaccine. If you are driven to take the vaccine, if you think that vaccines are good, probably you will tell your patients to take the vaccine. Okay, moving on to the second scenario. I think probably we've addressed the vaccine hesitancy. Now, we have this patient who has COPD, comes to your clinic, multiple visits. He has seen the cardiologist also. He has seen the nephrologist for some other reason. He sees the physician for diabetes. But none of them discuss the pneumococcal vaccine. So why do you think this happened?
First, ma'am, is the awareness among other physicians and other specialities, that which are the group or subgroup of patients who have to take. Like in children, we have a universal program, like every child has to undergo the vaccination. But when it comes to adults, there are some groups, some subgroups, some age limits, above 50, above 65. And many a times when there are no clear-cut guidelines, it becomes very confusing for the physicians or other specialities. So having a proper guideline, telling them might help other people also or other specialities also that, these have to be taken.
Excellent. So there's been a missed opportunity, and like you said, lack of strong recommendations. But Dr. Talwar will not accept that. Now that Indian guidelines for adult immunization have come, we have a lot of recommendations, a lot of Indian societies recommending vaccines in India right now, but then the vaccine recommendation goes way back, I think 20, 30 years in the West, where they have a strong recommendation for adult immunization. Probably in India we don't have, and it's coming up. And I think over the last 10 years, definitely things have got better. There are a lot of societies recommending vaccines. And so this basically calls for a patient-provider communication. There is something that we have missed saying it. So how do we address it? The first thing is we identified it, that it didn't happen. How do we identify it? If you've looked into a pediatric case sheet, it will have a vaccine history. Does any of your adult case sheet have a vaccine history? We don't do it. We've never bothered to look into it because we always thought that adults didn't require vaccine. The other thing that I used to always tell when I was sitting this 11 to 1 p.m., I used to always ask them, mobile ka bhi recharge nahi karoge to kya hoga? You can't use your mobile. So similarly, your body needs a recharge, probably a booster. Your childhood vaccine is not going to help you throughout your life. So that's something that we need to talk to our patients. That is the engagement that you need to be doing with your patient. Integrating vaccination into the hospital workflow. Probably, your EMRs, if you're having an EMR, at the end of your discharge summary, you should always ask yourself, was a vaccine given? Or in your clinics, when you have a case sheet, you're writing a prescription, and on your prescriptions, when you have all your degrees and names and written, and beneath you also have, all your medicines are available in this pharmacy and things like that. Maybe a line before that, vaccine recommendation. If we have that written in our case record, we would never miss that opportunity to vaccinate a patient. The third thing, standees. So if you put the standees, even if I forget, the patient would come and ask me, there's something that's lying outside your office. Like, I think Dr. Talwar has a poster of himself taking a vaccine. That's what I heard. So patients would come and ask you, even if you forget to take a vaccine. Even if you forget to recommend the vaccine. And, it's a zamana of TV. I can't be sitting waiting 1 hour for the consultation to happen. I need to be entertained. So you have a TV. Please run Amitabh Bachchan on it or Hema Malini taking a vaccine. Probably your patients would be interested in taking a vaccine. Moving to the third one. So we've addressed our patient provider communication. A 40-year-old wants the XYZ vaccine, but cannot afford it. We've already discussed that all of our vaccines are expensive. So any one of the expensive vaccine, he wants to take it, but he feels that it's too difficult or he can't afford it. So what is your challenge? How would you get that patient take the vaccine? He wants it, but he also tells you why he has a vaccine hesitancy. He says, I can't.
The basic thing here is that the 40-year-old who wants the certain vaccine but is not able to afford, the thing comes that affordability, we have to tell the patient that this vaccine is coming out of a lot of research. So you need to pay for it. And another issue that is there is that the insurance companies are not ready to pay for it. So that is another thing. But we should make him understand that hospitalization, taking recurrent courses of medication, taking recurrent courses of steroids would ultimately lead to excessive cost than the vaccine cost. But then we should also look at the scenario that whether the vaccine is actually required by him at that moment of time, looking at his age. And if he is having any comorbidity or any chronic disease, then yes, it should be done.
Excellent. So that's basically, the lack of insurance coverage. It's not just in India, even in the West, many of the vaccines are not covered by insurance. There are some vaccines which are covered, but that's on an outpatient basis. So when somebody is admitted, probably, that could be an opportunity for you to vaccinate that patient. Maybe it would be covered with his insurance. But I think there are a lot of insurance companies which are coming up, which includes vaccination in their coverage, because preventive health is building up in India, and then, we're looking at a healthier India. And another incident, I would say, how it changed my practice. My teenager son happened to buy a shoe which costed 8,000, and coming from a middle-income family, I was like, oh, 8,000 is just too much for me to afford. He just said, Amma, for 1 year if it comes, it's about 2 rupees that I spent. You can't spend that 2 rupees on me per day for my comfort. So I put that chorology in everything. So if you are talking about a vaccine which costs 10,000, one vaccine, 20,000, 2 vaccines, and it can give you a protection for 10 years, that's probably, we're talking about just 5 rupees per day for 10 years. I think we can invest that 5 rupees, because if I go to treat that, like Dr. Vidushi said, it's going to be pretty expensive. So this is how I break the cost and explain them, and no questions asked. They do take the vaccine. So I think these slides were already discussed. We spend a lot on, once we get admitted, we spend a lot on hospitalization, but we never think about preventive health. And I think this slide was also discussed. So we don't discuss about how much money we've saved in, preventing a cancer or eradicating an infectious diseases, and the cost effectiveness. And as Dr. Guleria already discussed this, the other thing is equity of health and impact of life. Okay, moving on to the next case. Mr. Raj, a 45-year-old businessman, is traveling from India to Nigeria for a 3-week trip. His medical history includes type 2 diabetes, hypertension, and bronchial asthma. So he visits your clinic. Most of you are pulmonologists. Now that you've set up a practice which vaccinates adults, now he thinks that now that I'm traveling somewhere, I need a vaccine. So we don't just deal with the 4 vaccines that we always discuss, influenza, pneumococcal, Tdap, or Shingrix. What would you advise him? Because now your vaccine clinic is building up. Now you've gone into a business of travel immunization. So what would you advise him?
Yellow fever vaccination.
Excellent. So don't worry. We are humans and not machines. So there is AI, there is mobile phone in all our hands. We have help that can be taken from the mobile. For this patient, he would require yellow fever. That is mandatory if you go into Nigeria. Other vaccines that he requires is hepatitis A, typhoid, meningococcal. Many of our clinics won't be able to provide yellow fever. So in your city, you need to know where yellow fever is given so that you could guide him to take yellow fever vaccine. So I just wanted to say that there are certain guides which we can go through. It's not necessary that we need to know about all vaccines or their recommendation. I usually, look to this website, Fit for Travel, which basically gives me all about the travel immunization or the chemoprophylaxis or anything that the patient would require. My last case. Mr. Sharma, a 55-year-old male with interstitial lung disease, secondary to rheumatoid arthritis, is planned for rituximab. He has a history of recurrent respiratory infections. He uses corticosteroids and immunosuppressants. And unfortunately, there was a missed opportunity, or maybe because of his prior vaccine hesitancy, we missed vaccinating him. But now that his disease has progressed and he requires monoclonal antibodies, when would you vaccinate him? This is some question which always comes up. So what and when pre-biological therapy vaccination? What are the vaccines that you would give?
He would, this patient he's on immunosuppressants and he will need rituximab also. So he's at a higher risk of respiratory infections. So all the pneumococcal, the herpes vaccine, the influenza vaccine, the regular respiratory vaccines he need to take. So this is mandatory. And right now, the COVID vaccine is not available, but it was there in previous guidelines, shows that COVID vaccine is also important for this patient.
When would you give?
Prior to him starting rituximab, actually prior to starting any immunosuppressants, but when he's already on immunosuppressants, we cannot stop them. So I think whenever it is possible, we need to give it to him.
Do we need to wait to start the rituximab? Can I give the vaccines and the next day I can, give rituximab for him?
The efficacy of the vaccine does take a little time, at least 2 weeks. So if that is possible, then we need to wait.
Excellent. So we need to know what we are treating and how we are treating. So rituximab is a B-cell monoclonal antibody. So generally, the recommendation says that if you are giving rituximab, which is going to knock out the B-cell response, you need to vaccinate the patient earlier, like you said, at least 2 to 4 weeks before, so that there is some antibody response. But in certain cancers, when I cannot wait and I have to give him rituximab, can I go ahead and give him rituximab and not give the vaccine?
I think we give both together.
Okay, so that's a very difficult question to answer. Definitely no, if I give the rituximab vaccine today and tomorrow rituximab, it is not going to work. We look into this, frequency of how you give the rituximab. So if you're planning to give rituximab once in 6 months, the recommendation says that probably you can plan the vaccine 5 months after the first dose of rituximab. So you have 4 weeks for the next dose. So you still fill into that gap of 4 weeks before and 5 months after the first dose. And if somebody is on corticosteroids above 20 milligrams of prednisolone, again, you cannot vaccinate that patient at that time. So you need to reduce your dose when especially in post-transplant patients where your immunosuppression is high. You need to either vaccinate them pre-transplant or when their immunosuppression is stable, maybe probably 5 to 6 months where you reduce your corticosteroids, you could vaccinate them. And to this, probably influenza is the only exception. You can always vaccinate the patient at any time because you're going to give multiple doses of influenza vaccine anyway. And for a healthy patient, you can always go through this chart, something called as HALO, which basically says the health, looks into the health factor, age factor, lifestyle factors, and the occupation. So it's a ready reckoner. So if you don't know what to vaccinate, probably you can look into the chart and it would tell you if somebody is an alcoholic and he is of probably, 40 years old and he's somebody with, homosexuals or he is on the streets, then probably he would require influenza and pneumococcal vaccine, something like that. And AI is going to help us. I'm sure it is going to, take care of all your appointments. If appointments, many a times we give the vaccine and then we don't call the patient for a booster because we don't know when they took the booster. Probably AI will help you in your clinic appointments or regular reminders to patients that you need to take your annual flu vaccine. And when we talk about vaccine equity, I don't know if you know what this is. This is basically the Reliance daughter who says, Papa ne Dadaji ka sapne ko pura kiya. Do you know what this is? I don't know how many of you know, in 2004, when Reliance Communication at that time, they brought their mobile, their tagline, do you know the tagline? Baap ka sapna, sabka apna. A mobile in everybody's hand. And you will accept that right now, all of us have a mobile in our hand. So probably in 20 years, all of us would have taken vaccine. And going by Dr. Guleria's chart of, 25% above 60 years of age by the end, I think all of us would be vaccinated in that age group. So with that, I end with the saying, okay. Oh, I think I have to move with this. Yeah, so with that, I would say vaccination aren't just for kids, they are important for adults too. Knowing is not enough, we must apply. Willing is not enough, we must do. Thank you.
I think we'll have the questions in the end. So what we'll do is we'll just can we have the introductory slide again? No, this is the other one. So meanwhile, can I request we have Dr. Neha from an ID specialist from Medanta, Gurgaon. So can I have you on the stage and join us as a panelist? We'll love to hear your opinions too. I don't know if the next speaker also wants to get questions right.
I'm from Fortis Gurgaon and I'm founder of NG
So I
Swasta.
think
Thank you so much.
that's his problem. Your introduction was Medanta.
I
Doesn't
was
matter.
in
Gurgaon.
Vedanta for 10 years.
I think Gurgaon
Thank
is
you so
right.
much. Yes.
So ID specialist from Gurgaon.
Yes, thank you so much.
हाँ इसी को करना है आप यहाँ नहीं आ रहा ना यहाँ तो आप लाओगे ना इसको ऑन कर दो anyways can I request our next speaker Dr. V. Ramasubramaniam to please be on the stage. He is consultant ID from Apollo Hospitals, Director Capstone Multi-Speciality Clinic, an expert in antimicrobial stewardship, tropical medicine, adult vaccines, and we'd love to hear you. So kindly come up. He's going to speak on how to set up, I think a very important aspect, how to set up an adult vaccination clinic. Can we have his slides, please?
Good evening, everyone. I'd like to thank Deepak Talwar for the invitation, and I'd like to proudly say that when I was doing my MD, both Guleria and Talwar were my senior registrars. They were doing their DM chest when I was doing my DM and when I was doing MD in general medicine. Good times. I'm going to start with first dispelling a myth. One of the commonest questions and answers which I hear with regards to why adult vaccines are not doing well in India is, everybody says it's the cost, which I totally disagree. It is said that India is a developed country with third world problems. So the question of affordability for adult vaccination is a pure myth in our minds. I think most people, apart from, of course, those who are attending government hospitals, most people who seek private health care for their daily needs can very well afford all vaccines, including Shingrix vaccine. So if you ask me then what is the obstacle, what is the reason why it is not coming up? Unfortunately, it is all of us. It is the healthcare providers who are an obstacle for adult immunization. This is very provocative, but it is true. I've been practicing adult vaccination for about 18 years now, and I find it is us doctors, and I include me in that, we have a hesitation. When it comes to a proactive intervention where there is a possibility of side effects, we shy away from it. We are worried for various reasons, which I will tell you shortly. And I hope that the reason why I'm here for the next 15 to 20 minutes is that this is very, very common in India. Cosmetic medicine is very well accepted, even though it is very expensive. But when you say a vaccine for an adult, there is a lot of hue and cry. And I hope that this 20 minutes, we will have an insight into what we can do and why are the reasons why you are not able to do to help us solve the problem. And this starts with, the journey starts with understanding why we need vaccines. This Dr. Guleria also presented that as we grow older, there is something called immunosenescence, which means our immune system weakens as we grow older. Typically begins by the time we are 30, but markedly pronounced after the age of 50, which means that all of us, as we grow older, need vaccines for staying healthy, just like children do. But if you look at the status of adult vaccines in India, adult vaccination in India, you'll find probably large corporates have adult vaccine clinics. There are very few standalone clinics. Mine is one in Chennai, but I can probably count in the number of fingers of my hands as to the number of standalone clinics in India. Yellow fever vaccination is accepted. Educational travel, if you have children who are over the age of 20 who are going to the US or UK, they need vaccines. It is mandatory. The universities request vaccines, so these people go and take vaccines. Elderly people, if you have a son or a daughter in the US who's going to have a baby, I'm talking about the older group here, it is always the child calls from the US to say that my doctor has said, before you come to the US to help me with my delivery, please have your Tdap vaccines. Tetanus, diphtheria, pertussis is mandated. Flu vaccines is being more accepted. And of course, COVID vaccines, unfortunately, didn't stand up to the hopeful ideas we all had that will kick in adult immunization in India. So why is it a challenge? The most important is lack of awareness, and not just among the public, awareness among doctors. Very few doctors understand the necessity for adult vaccine. We don't have a data of disease burden. When I talk about pneumococcal vaccine, the first question pulmonologists ask me is, I've been a practicing pulmonologist for 20 years, and the number of pneumococcal proven cases I have seen is runs in just probably 2 figures. So we don't diagnose it properly. We don't have the data of disease burden. We don't have recommendations or very limited recommendations. Affordability is a problem. Accessibility. Where would I take a vaccine? If I'm living in, say, a part of Delhi where I don't have a nearby vaccine clinic, where would I go for the vaccine? The side effects of the vaccine, which come in the newspaper, put us all off. And is it cost effective? I think Dr. Madhumita made a very clear point that spending 5 rupees a day is going to keep you healthy. You put it like that, it's just like a health insurance. And to start with, we have already got the comprehensive guidelines. There are some errors in this, but still, this is something to start with. So this is something we need to look into more. But if you look at specifically in India, what is the problem? We don't have a national program. As I told you, there is a reluctance amongst healthcare workers. The doctor recommends, the patient goes to the general practitioner, the GP says, you don't need it. It's a Western cheese. You don't need it in India. There are many media and legal issues. Whenever a vaccine camp comes in, for example, the measles camp in India came in, child dies after measles vaccines. 3 girls enrolled in the cervical cancer trial die. You see a news like this, it puts everybody off. But when you go in and find out why those 3 girls died, why was it related to the vaccine, you'll find that one died because of a love failure. She committed suicide. The other had a cancer which was not related. And the third died in an accident. Nothing to do with the vaccine. But the news carries that 3 girls in a cervical cancer vaccine trial die. It has a phenomenally negative impact. The questions of, do you need to take a consent before vaccine? We don't think twice about writing antibiotics. But when it comes to vaccine, kya kuch hota hai to kya karenge? Guidelines, there is a difference between Western India. Patients, this is another important reason. What is known as the optimism bias. You tell any healthy person, take a vaccine. Kyon? Main to fit hoon. You don't think that flu can kill people. Lastly, accessing vaccines. But the most important thing is what was alluded to by the previous panelists. The reason why most people don't take vaccines is the client requirements are very lofty. I take this vaccine, I won't get flu again in my life at all for the next 30 years. Versus the budget. No, I can't afford the Shingrix vaccine. So these are the practical problems we all face. So how do we get over it? We need to encourage adult vaccination by improving awareness among both the healthcare workers and the public. We need to come out with guidelines. Our hospital administration has to have a buy-in. We need to integrate services. We need champions like Amitabh Bachchan for Shingrix. We need more people like that. But most importantly, we need to set up more adult vaccination clinics. Unless there is more noise and availability, we are not going to get there. So how do we plan an adult vaccine clinic? You need to locate it. If you are running a hospital, the vaccine clinic should be clearly visible. It should not be tucked somewhere in the basement. Though in my hospital it is in the basement, it is still very well established. It should be where everybody sees. People should ask, what is this adult vaccine clinic? It should be accessible. Wheelchair access should be there for the clinic. You need to have staffing for this. You need to have people trained for this. Actually, if you are having it in your private clinic, all you need is one person, nothing else. One trained staff, maybe a staff nurse, maybe a counselor who can give the injection. That's all you need. You need a 10 by 10 room where you have a freezer or a fridge for the vaccine. You have a table and a chair and preferably a couch. That's all you need. And of course, for documentation purposes. So there is a waiting, this is ideal, a waiting area, an entry room for registration, a doctor's chamber where it is given, payment counter, area for entry and maintenance of records, vaccination room. This is a very, swanky clinic, but all you need is a very small room, and the only thing you need is an intent, a passion to give vaccine for adults. You need to have responsibilities, so you should have a protocol in place. That's the only thing. So you need to see how, if a patient walks in, starting with Dr. Talwar's photo, taking a vaccine, to people asking, what is it? How do we do it? What are the benefits? And Dr. Madhumita raised 2 or 3 wonderful points. You have a standee. You have a television which says, puts in Amitabh Bachchan's advert. You have a counselor. I, in my clinic, have a vaccine counselor. She's called the vaccine counselor. She's a nurse who's been trained to counsel for vaccines. So what I do is, in my EMR, when I write, just after the prescription of medicines, it is written vaccines advised. So I'm forced to see that every time and forced to tick it off. Flu, pneumococcal, Shingrix, Tdap, others. That's what I have. So which means every printout I take of the prescription, I have to tick it or say no. At least I take a decision based on it. And then I say, Ms. Sindhu will counsel you outside, and give it to her. And Sindhu does a wonderful job. Even Shingrix, she manages to counsel and give most patients. So that is all you need, nothing more. You need to have a cold chain. People are afraid about this. It's actually not difficult. A freezer is ideal, but even a refrigerator should actually do. If you're storing very minimal number of vaccines, a refrigerator is enough. You need to make sure that you don't store vaccines in the door of the refrigerator. You don't store vaccines in the freezer of the refrigerator if you're using a common refrigerator. And make sure that depending on the requirements, you have a temperature meter which will monitor the temperature in the fridge and document it at least twice a day if possible. So this is simple things which you do. If you have a freezer, you need to have a system whereby which vaccine is stored where, which is on top, which is on bottom. And depending on the turnover, you can decide what you need to do. You need to have a system for safe disposal of, a safety for handling injections, and a safe disposal for the medical waste. I think these are all mandatory in any clinic which you need to do. Most importantly, a vaccine card. So anybody who comes into my clinic who has had a vaccine before, if he says his name, they check up and say, you've had your flu vaccine, you've had your conjugate pneumococcal, you're due for your polysaccharide in another 2 months' time. The record is given. They are given a card which they are supposed to bring every time. Most of them don't bring it, but we have records so that when they come, we know what vaccine they have had before. And maintaining records, sending SMS reminders to them every time they need a booster makes a big difference. They feel cared for because you say your flu vaccine is due, please come and take your flu vaccine. So all these are simple things which is possible in all clinics, but makes a big difference with regard to patient. And if the counselor can call them up and say you're due for your vaccine, they feel very happy. So I will tell you briefly in the next 2 or 3 minutes about what we did in Apollo hospitals. We started our vaccine clinic in 2011, 2012, I don't remember. And it was a tough run. I'll tell you what are the things. The most important thing which we had was the administrative support. The management said, set up a clinic. And we wanted it as a one-stop shop. So the patient, this is in the infectious diseases department. I told you ours is in the basement. So they come in, they meet the secretary, come and see me. Anybody who sees me, before they leave my room, I say, the vaccine clinic is the opposite room. This is the vaccine, you need to go and take it. So they go there, and they send them to the billing counter, which is the receptionist desks. They pay the money, go take the vaccine, and walk out. So unless it is accessible and quick, half the times, if you're going to say, go to the second floor and take the vaccine, they go away. It should be, when you write it, it should be available within, eyesight. We stopped all pharmacy sales of vaccine. We said only the vaccine clinic is licensed to give the vaccines. You cannot buy any vaccine in the pharmacy. We said no. The only exception was rabies immunoglobulin, which they could buy and take it in the emergency. Otherwise, no vaccines. Because we found that people used to buy pneumococcal vaccine, because it was crowded, they used to go home, or if they're in a hurry, come the next day with the vaccine in their pocket and say, can I have it now? I bought it in Apollo Pharmacy only. No. These are things we learned. So we completely banned it. Other departments, we said, have to send the patient only to the vaccine clinic. Nephrology department, where hepatitis B vaccine is mandatory. They have to come down and take it. If it is a cardiology or a rheumatology patient, we gave seals, rubber stamps to all the consultants saying pneumococcal, flu, and Tdap. That's all. Don't be too ambitious. 3 vaccines. So every time we have few cardiologists and pulmonologists, all they'll do is when they finish seeing the patient, chuck, take it and send it. They will come to the vaccine clinic, take and go. So there was a lot of cohesion. A&D, as I said, it was only for, A&D is only for rabies vaccine. Otherwise, no. The vaccine clinic was open from morning 9 to evening 6. Everything was done then. For inpatient, we brought in a standard template saying pneumonia, pneumococcal, and flu vaccine. Anybody who was discharged, this had to be ticked in the EMR. So most cardiology and pulmonology patients at the time of discharge automatically got flu vaccine and pneumococcal vaccine. Most of them did not raise anything. This added probably about 4,000 rupees to their bill, but when the bill runs in maybe a lakh or two, 4,000 did not make a difference. The perception of patient can't afford is here. Most of the patients don't question. That is what's by default. You don't give them a choice. By default, it is necessary, and this is a necessary intervention. We are not talking about luxury. You take American Gold criteria, you take American Diabetic Association, American Cardiological Society, they all recommend vaccines. Why is it that we are happy to give industrial doses of statins? Because it is recommended, but we quietly cut off the vaccine recommendations and say the patient can't afford. Can't the patient, if they can afford 5 to 10,000 rupees a month on medication, your statins and your anti-diabetics, and probably even, Ribelsis and other Ozempic, why do we hesitate about vaccines? It is in our minds. The Master Health Checkup department, we put counselors, we started registrars in our department, and we found that at least 30 to 50% took vaccines. But make it simple. The counselor should speak. They should go across the hall, pay, take it and go. You send them to another floor or another area, they just go away. And documentation. We also brought in documentation in the case files in the wards so that if they had it in the OP, the case records will show that they've already had the vaccines. But what is needed? We need a little more noise, more meetings like this. We need education for doctors, legal issues. I'm still not very clear about this. If we had 2 major complications in the last 12, 13 years. One patient developed a bad intramuscular hematoma, had to be operated. Fortunately, there was no major problem. Another person, this person was going to the US for immigration purposes, had a vaccine, developed a brachial plexus neuralgia. Very uncommon complication, and it took about 6 months for him to recover. But because he had come for the vaccines, there was no problem for us, and when we showed this can happen for vaccination, it was all right. But side effects can happen, so you have to be careful. I'm prescribing a few medicines now, but I suggest you get a second opinion from a competent court. Because unfortunately, judges deem it fit to give opinions on medical matters without medical expertise. This has to change. Accountability, administrative support, IT backup, and some sort of incentivization will make a big difference. Lastly, this also Dr. Madhumita showed, it is a personal physician who makes the difference, which means all of us have the power to make a difference, a positive impact on a patient's life. So let us not stop doing it just because we perceive that the person cannot afford. If we take the vaccines, if we can afford to give the vaccines to our parents, we can very well recommend it to our patients. You know, choice is different. And I'm not talking about government patients, so please, we are talking about private healthcare. Lastly, we need to have some out-of-the-box thinking. Annapurna Atta was 165 rupees, now only 164.90, you know. Why not? And this is found even more fascinating. Are you an alcoholic? We can help for liquor home delivery. So, unless we innovate, unless we create a disruptive change in the existing scenario, I think we are not going to win this war. Lastly, vaccines do not save lives. This may be a little contradictory, but I think we'll have to remove the chairs to find out what it actually is. The statement is, vaccinations do. Having vaccines is not going to help unless all of us are going to take and recommend it to our patients. So I think if there is one message you take home, please, this is it. And again, what Dr. Madhumita put in her slide, that knowing is not enough, we must apply. Willing is not enough, we must do. That is Goethe's statement. So we have to take it upon ourselves. As I said, first get convinced that we need it, our family needs it, then talk to our patients. Thank you.
Why? We should take the consent. It's an adult vaccination clinic. That is the first point. Second, if a patient develops allergy with the vaccine or any other complication, why we should not have a center or it is attached an emergency department along with it? How can we set up an adult vaccination clinic without having such facilities?
Answers? I think it's your...
I never said consent is not required. I said there is no clarity on matters in India whether consent is required for vaccination. Nobody knows. When you come to a doctor for treatment and he advises a vaccine, it basically becomes an implied consent. I've come to you and whatever you advise, I'm happy to take. So like all things with antibiotics, you don't need to take separate consent for everything. Only for HIV there is a consent required. So the consent is implied, so you don't need it. At least legally, there is nothing to say you require it. But if you tell me, no, I'll feel happier that something goes wrong tomorrow, I'll take consent, perfectly fine. But there's one small caveat is, whenever you ask a patient to sign for something, it's very unlikely that he's going to sign it. Whatever it is, you know, it's a discouragement. So that is the thing. Second, yes, side effects can happen. Like any antibiotics or any medicines which you give, vaccines can also cause side effects, though vaccines have been one of the most extensively researched, studied interventions. Still side effects happen. So you need to be prepared. You need to have epinephrine. You need to have somebody trained in resuscitation when you have it. As I said, I have run it for 13 years. Mine is an outpatient clinic. I have it both in Apollo and in my clinic. So far, I have not had any issues in the last 13 years. I've had thousands of doses given. I've not had. If at all they say I'm feeling dizzy, you make them lie down, nothing happens. You check the blood pressure. But you need to be prepared, have a epinephrine syringe, and which is the same for any medicine. And you need to have connection with a hospital where in the event that he needs transfer, you're able to transfer it. But the chances of this happening is very, very low.
Yeah. I think we'll have more audience interaction in next few minutes. So should we do it for 15, 20 minutes? So we have a go-ahead for... So may I request Dr. Madhumita also to join? I think, so we'll go like our first session. Probably the questions or the discussion will start from the panelist, and then you can give your expert opinion. So, see, we have already had some case scenarios, and I think the next session is all about, as I look through the program, it's all about case discussions and how vaccines fit into it. What we'll discuss are things which I think all of you have touched. Some of the slides I was realizing are probably could be similar, although we never knew. So let's talk one by one of the two sessions. So look, let's start with the challenges in the adult immunization. So I think the most important question would be, if the slides move forward, that would be helpful, but let's see. So bottlenecks in adult vaccine. So I'm not going in for clinical things. We have an ex-director of AIMS and some people from the government setups here. So it's very important to understand where are the bottlenecks for the adult vaccination. We have had a lot of things. Your perspective, I think more or less they have been immunized, but Siddharth?
So the bottlenecks in the adult vaccination are, the first and foremost thing is the awareness. Awareness amongst the caregivers, the health caregivers, as well as amongst the general population. That is the major thing, the bottleneck thing is. And another important thing is there is no Indian national program of adult vaccination. So if it is there, like universal immunization for children, then I think that it would become more easy. So everybody will be much more aware. And other thing is that implementation of all these things and having the vaccination clinics, those are the issues which are not there.
You can all say one by one. I think it will be...
Rightly said, awareness is important. Second, accessibility is also a big issue because vaccination clinics are not available at every place and people refrain from specially going to a hospital to get a vaccine. So even when the standalone clinic is there, if they do not have, they are not able to guide the patients properly where the patient should go to get the vaccination. So this is important. And awareness, apart from the general population or the people, our colleagues also need awareness, our other specialty people also need awareness that this is also an important thing. Many times I've had referrals from other specialties just for the advice for vaccination. I mean, I'm not complaining, but still that is important that everybody knows that these vaccinations are important so that wholesome coverage can be there.
So building upon what has been mentioned, it's awareness among the general public as well as the denial. Many patients feel that I'm healthy, I don't need to take the vaccine. And they don't want to take up the vaccine because of the possibility of side effects, that what kuch hoga to nahi, bukhar to nahi aayega, kuch pain to nahi hoga. These are the other common questions. So for this, I think it's important to create awareness. And one of the things which is about taking up, or I mean, I've just heard Dr. Talwar having his own poster, which definitely will make a difference. And I also recently posted my own picture, as Dr. Madhumita also did. And my few of my patients have seen that and then have come forward for the vaccination. So it's about we taking it and then creating more awareness and acceptance in the community. That will help.
Anything else? Because you guys have already... So I think more or less it summarizes most of the things. And I think one of the key things is, I personally feel, and I think I agree with the speakers, is that since adult vaccination is not universal, it's become more selective. So once you have selection, then it's a selection bias. It depends on the problems with our healthcare workers, our doctors, our colleagues, not themselves having the acceptance to actually take it and then to give it. And then obviously costing and the accessibility, the lack of specialized adult vaccination clinics probably would differ. And I think we'll move to the next question, very interesting, which
but I will add one
please
thing
add.
About the accessibility. I agree with the awareness is not there, but accessibility is a chemical locha in our brain. It is not that it is not accessible. All pediatricians give influenza vaccine. All pediatricians even give pneumococcal vaccine. When as adults we treat pediatric patients also. Sometimes pediatrics treat adults also. So if you want to take a vaccine, you have clinics providing them. So pediatricians do give influenza vaccines.
I think this is one of the questions. We will just hold on your thoughts.
Okay.
It's an important thing actually to discuss. And I have my views, and I think we all will have. Because you are an ID specialist, you cover pediatrics and adults. It's not the same now in many, many corporates and many hospitals. So we just hold on to your thoughts. We'll get back on this. I'll just, probably it's a very important thing for us that as healthcare personnel, since I feel it's a very big missed opportunity among our peers. And I would be really interested in knowing your stories and how you have overcome this among your peers. ID people, pulmonology, if there are physicians, because it's a tough thing. I feel that, Dr. Ram, you said that we have made a stamp where in a corporate hospital they're going to refer patients to you. It's a great job, because that's a bigger hesitancy probably in sending patients even for a vaccination to a cross specialist. So those are tough things you have overcome. That is kudos. But I think, how do you overcome the vaccine hesitancy among your own peers? So I think guidance, we all know it. We all spoke that I think every society, every guideline for specific chronic diseases has it somewhere down, but it has it. So by the time you read it down, you may be having a fatigue of reading through that guideline, but it does have.
No, as you said very rightly, there is a fatigue. All the guidelines, any guidelines, European, American vaccination is part of any standard of care for all illnesses. So you need to highlight that. Another important thing is, both flu and Shingrix, these vaccines not only prevent the infection or the complications of the infection, they also prevent cardiovascular and cerebrovascular accidents, which means by giving the flu vaccine, you actually reduce the number of heart attacks and strokes. So these are things you need to explain. And as I said, being a very strong spokesperson for adult vaccination over the last 15 years, I think it's slowly sort of eroded into our society also.
What about, that is one aspect in making our peers understand the use of vaccination for their patients. I'm actually taking to one step further, understanding that they first need to get a jab themselves. So how have you overcome that hesitancy? I personally felt it was easier for us to convince them to start using in patients than to the healthier, so-called healthier doctor in themselves. So
our clinic in Apollo hospitals, when we started, we gave free flu vaccines for all the doctors and the healthcare workers when the swine flu epidemic hit. Subsequently, we have narrowed it to areas where the possibility of meeting such patients is higher. That is emergency, ICU, respiratory and cardiac wards. In these wards, we are giving free vaccines. And we found that when this was given, at least most of the junior doctors, if not all, were willing to take it. The consultants were still a challenge, I don't think I need it.
Yeah,
that's the question. It's what is called the optimism bias. I don't need it. I've had flu in the past and nothing, I just have this thing. But once they have an infection and then suffer, that's the best time to tell them. I recently had a patient who, before they went to the US, I told them, take the shingles vaccine. They said, no, we'll think about it. They came back just last week, the husband promptly has developed herpes zoster ophthalmicus. So the wife is now hurriedly running to take the vaccine. So sometimes you learn it the hard way.
yeah, because Dr. Alwar, like you were saying about vaccination of your departments and getting it among your staff, I think since 2011-12 in my previous hospital for almost 10 years, we made it a point, we had a consultant club, a coffee room. So we used to, the moment the new flu strain would come, we'll stock it up in the fridge, right? And we will get a nurse on an appointed date that whoever wants to take a shot, take at the absolute landing price, which is far, far less. And you will be surprised that initially there was hesitancy. By the third year, a lot of our colleagues were ordering 5, say, for my father, my father-in-law. So we were from the initial, when we got 40, I remember, and we were finding it difficult to, I had said that if we can't take use of it, I'll take it to my clinic and we'll use it, don't worry. But by the third year, we were actually reordering it within the first few days. So it takes time, but I think and I think that then percolated into their use amongst the patients. So I think we all probably will have some success stories, some learning the hard way, but I think vaccine hesitancy among healthcare workers is a known phenomena. I think we need to do our bit in first spreading this knowledge among ourselves. So
I would just add that the vaccine hesitancy is for certain vaccines. So if you look into the continuum, these people are the ones in between. All the healthcare workers would have taken a hepatitis B vaccine. So it didn't take them time to convince to take a hepatitis B vaccine. So their hesitancy is basically for certain vaccines. So they all feel that, yeah, influenza is not going to do, harm to me. But you think that hepatitis B is going to do harm. Why? Because probably there was a recommendation that hepatitis B is a must for healthcare workers. Maybe if we start bringing that all healthcare workers should have influenza vaccine, probably they will take it. Similarly, in your pediatric nurses, neonate nurses, where, they need to take an MMR vaccine or a varicella vaccine, or they should have a history of varicella in the past. So when you start putting up policies like that in your hospital, I think there will be no hesitancy amongst healthcare workers to take a vaccine.
Agreed. So there are a lot of, the CDC recommends there is a proper guideline and a proper checklist for healthcare workers. I don't think that is there in the API separately for healthcare workers like this. So I don't think it is there. So how many of us would actually see that I think one of the issues convincing doctors is because if they look at the chances of developing that disease, number one, amongst themselves, which becomes very difficult. Secondly, the success rate or the efficacy. So I think Hep B, probably because of the way the success was in preventing Hep B related liver failures and all that, probably made the doctors, when we took it, we were postgraduates at that time. There were big angerics and everything. So you had to take it. It was available free of cost. Even in my internship in Maulana, that's more than 2.5 decades back. So I think government actually made a point in getting those things, and we'll come to the next important thing is these strategies. So how do you improve these coverages? Because that is also very, very important. It's very easy for us to sit here. A lot of us here are private practitioners. And I think the biggest challenge is when we talk to our friends from the government setups, it's not very simple. It's right 5 rupees a day. There are many things for 5 rupees a day which they have to spend. So I don't know, it's a day of change today in Delhi. So from 2100, the girls are getting 2500. So probably now we can start telling them you can at least spend 1 month's money which you are getting free from the government for some vaccine. So, but that's right. These are all ways we try and explain to them. But a lot of vaccinations, the so-called out-of-immunization program vaccines are expensive. It's not very, very simple. I think Siddharth would know. People coming in even to Patel Chest, which I find is a much more probably elitist type of patients, because they get it referred patients. They don't see walk-in patients. I'm an alumni from Patel Chest. So once you have those type, you have half of the patients have already been filtered out. Who goes for a referral and then come? It's tough. So even they would probably find it very difficult to. So Siddharth, we begin from you and then Sandhya. Improvement in adult vaccination coverage.
And we have to be quick. Very true, sir. In
we have to be quick,
also,
otherwise we won't be able to.
Even in VPCI also, when the patients are a bit better than the patients we get in other hospitals, but still they are very hesitant. The cost is another very important issue, but what we were thinking recently, that once the Pradhan Mantri Yojana, the Ayushman Bharat comes in, and can this adult vaccination be a part of it? Because at the time of discharge, if we are able to give them vaccination by Ayushman Bharat, it is a win-win situation for all the three parties. The government, it's doing good. For the insurer, because health costs will come down. Third, patient will get it. So that is the thing, what I think is the way forward now.
So and you are the voice. You are our voice in the government.
So we are trying for
and
it.
Whoever, sir still has a lot of clout in the. So CGHS, they don't give. They have, when I write a CGHS patient, please get a vaccine, they say go away. So Ayushman Bharat, which Delhi hasn't seen, probably from tomorrow it will be there.
It will be there, so
Insurance is very difficult. Even what you are talking of, very high-end insurances where they cover health checkups and preventive health, those are far and few. Anyway, insurance companies low. I think we have to sensitize government stakeholders. We have to make them understand that insurance companies, like we tried with sleep machines and sleep studies, that once the patient gets admitted for that disease, what you are actually pay out is far, far higher than what you are trying if you're doing preventive medicine. So I think we will move faster and faster. Preventive, we have already discussed about how MIST AI you touched. Probably we can have a sort of a AI type of inbuilt into our EMRs, where every time it pops up that these vaccines are missing, if he goes to any of the consultants, there is a pop-up which comes, please tell him to get vaccinated. I think that would be a good idea in a renal failure patient or a cardiac patient, because they have so much on their plate. There's so many things to probably write and do and convince. They have to convince for angiography, angioplasties, those big dual chamber pacemakers. So this is a very small menial thing for them to sit and convince. So I think lastly, I'll not go what you were saying. My biggest probably challenge is for an adult vaccination: who, where, when, right? So who should all of us be doing? ID people be doing? Pediatrician should be then doing? So no, just I'm talking about dedicatedly. I have been doing vaccinations in my pulmonology clinic for last 2.5 decades. It's not a vaccination clinic. What he's running is a vaccination clinic. Then you should be ready to take care of travel vaccination. You should be ready to take care of everything. What we are doing is our respiratory vaccines advised or probably giving. I may stock up maybe a pneumococcal or influenza. I feel that unless we have dedicated vaccination clinics, we will still not reach what we want as vaccination, maybe the coverage to improve, because then we are doing part type of work. I feel that, like you were saying, yellow fever should be available. Tie up with the government. Maybe travel medicine, somebody is going, coming, you should have all the facilities then to probably do.
No, I'm saying it doesn't matter. We don't need to aim for perfection. If you're able to give pneumococcal flu, good enough. If a cardiologist is able to give 2-3 vaccines, that's fine. So let us not look at, if we are going to have a clinic, it should be a comprehensive, all vaccines, travel clinic, not necessary. I think the more we improve awareness and the more accessibility is given, I think that's the way forward.
I think because we have discussed most of these societal things, one last round of words on these two topics before we close?
So I have learned from Sir, close to maybe 12 years back or something like that, when he was taking up the lecture in SITSCOT. And I have recently started my vaccination clinic in Gurugram. It is the most common vaccinations, of course, flu and PCV and Shingrix. So important is to mention that unlike the COVID-19 vaccine, which was not given to the children, influenza vaccine is given to kids, which is safe. So it's equally safe for adults as well. So I think it comes with safety as well. I mean, in my practice, it's not so much the cost, but it is the safety which becomes a concern for the patients. So if we mention, and also the other thing is we can make the villain much more bigger. Like the cost of a patient who develops pneumonia perhaps will be in lakhs or maybe 5 lakhs. And the cost of the vaccine is hardly 4K. So that will really help us in having the acceptance for the vaccine. And in fact, my own mother, she developed shingles. So it was very bad. We picked it up on day 1, but she could not sleep for like 7 days. And it's not just that, we also, yeah.
So I think with that, should we close the session?
Yeah.
Because I think we still have a lot of interesting cases to discuss. Thank you, the speakers and the panelists. I think a lot of take-home points for how we all manage our vaccine hesitancies and stuff. Thank you so much.
Thank you, sir. And thank you, our panelists who actively participate in the discussion. So all the felicitation ceremony we'll do in the last, in the interest of time. So in the last session, we have case scenarios. So I would like to invite Dr. Kanishk for the case scenario presentation. And to moderate this session, Dr. Madhumita, please be on the dais. And we have expert for this session, Dr. V. Ramasubramaniam, Dr. Randeep Guleria, and Dr. S. Chakravarti. So Dr. Chakravarti is a renowned physician in the Metro Multi-Specialty Hospital, Noida, and he's having more than 20 years of experience in the field of medicine. And we have a panelist with us, Dr. Lavleen Mangla. He is a senior consultant in the Department of Pulmonary Medicine, Metro Hospital, Faridabad. Dr. Vipul Mishra and Dr. Ankit Sinha. Dr. Ankit Sinha, he is a senior consultant at Yashoda Super Specialty Hospital, Koshambi.
Good evening, everyone. I think we had a wonderful discussion in terms of lecture format, in terms of question answers, in terms of experience, and this is like a grand rounds. We'll be having a discussion. I'll be giving some case scenarios, and first I would request the audience to raise the hand and answer the question. Because now everything I think have been discussed. So I'll start with the first case. So it's a case number 1, which says a 51 years old female, never smoker, BMI of 28, with diabetes mellitus, HbA1c 8.5. She lives in a remote place in Bihar and will leave in 2 weeks' time. So she is here for 2 weeks. And she will be going back to her hometown. She has a history of severe asthma. Absolute eosinophil count is 1200. IgE is 126. She is on high dose ICS and LABA at this moment. On PFT, the FEV1 is 59% post bronchodilator. But she has never received any vaccine as an adult. So I'll be highlighting the important points over here. The patient is having diabetes and she is leaving in 2 weeks' time. So we have 2 weeks' time for the vaccination. The patient is asthma, so she is taking high dose ICS at the moment. And she has never received any vaccination. So I request audience, if anybody wants to answer this question, what vaccine she needs right now and when it should be given. Okay, so we'll move on to the panelists, I think, because we are running out of time maybe, so it will take a lot of time for the discussion. So for the panelist, Loveleen sir.
I think that this patient is already having asthma, more than 50 years of the age, and she is also diabetic also. I would like to give her all the vaccines, all adult vaccinations, including influenza, your pneumococcal, your shingles, and we need to ask about her previous vaccination history because she is on the Bihar also. We need to ask about her MMR, DTB, and the hepatitis B vaccinations also, particularly. And all these vaccinations we should provide her. And if in case like we may not be able to, inoculate all these vaccinations in these times in the 2 weeks, we need to give a proper card, and those vaccinations need to be, taught to her, like for maybe some patient or nearby relative who can give them the vaccination. In the Bihar, maybe it's not like that we cannot give it in the Bihar these days. Yes, and all this should be there for this patient.
So I think the issue is that if you have to give it immediately, what would be the two vaccines? Probably the patient has a compromised respiratory status. She's an asthmatic, she has poor lung status and is immunocompromised and is more than 50 years of age. Probably the first few vaccine that you would like to give is influenza and a pneumococcal cover. You could give both of them on the same day on different shoulders, and then follow up subsequently with by making the patient aware of the entire vaccination schedule that she needs and trying to provide that either at Bihar or when she comes for next follow-up.
So the problem that can happen in this. So the current scenario, the problem that can happen is that she will leave in 2 weeks' time. The second dose of each and every vaccine which you are giving will be missed.
So, sir, sir is saying that PCV13, first we can give PCV13 and the next vaccination can be given.
It may not be available in Bihar.
So, next can be given in 2 to 1 year of the time, within 2 months to 1 year of time.
Polysaccharide vaccine, the gap between the PCV13 and the polysaccharide vaccine should be at least 8 weeks. But it can be longer than that. So, if the patient comes to follow up after 3 to 6 months, you could still
Actually,
give it.
ICP recommends that, there's a lot of confusion between, the duration between 13 and 23, though they have said that the duration should be 1 year, irrespective of what serial number you are following. That simplifies the process. So, PCV 13.
Yes, you can even give it. You can give it even up to 6 months.
So, in this scenario, we have diabetes mellitus. So, the question comes to our mind that when the patient is having diabetes, do we need to play with the dose of the vaccination which we want to give? Should we take extra precaution? What if there is something else we should do for the patient of diabetes?
To me, I'll keep it very simple. If the person is above 50 years, irrespective of any comorbidities, flu vaccine is necessary. The next dose is 1 year later, so there is no question. A conjugate pneumococcal vaccine. Whenever you give the pneumococcal vaccine, the conjugate vaccine should always be the first vaccine, irrespective of what the other conditions are. Things have become very simplified. And a polysaccharide vaccine should be after 1 year in immunocompetent individuals, which she is. If she's immunocompromised, it is 8 weeks. So that's also possible. She's immunocompetent, so 1 year later, not a problem. Shingles vaccine, if she can take it, 1 dose, that's the only thing, because the second dose has to be given preferably in 6 months' time, 2 to 6 months' time, and a Tdap can be given. So if she's willing, I will give 2 on this arm and 2 on this arm. It's a same day. All 4 can be given on the same day without any issues, except the arm where the shingles is given, it will hurt a little bit and you may have a little fever. But other than that, if they are willing and she has the money, keep it simple. The only extra vaccine is hepatitis B. In diabetics, hepatitis B has to be given. So ideally 0, 1 and 6. Yeah. So, and hepatitis B should be available in Bihar.
Chakravarti sir.
And American Diabetes Association and RSSDA in India, they have given the same guideline as we are following in respiratory cases. So here I have devised something different nowadays. We have diabetes educators with us, those who educate the patients regarding insulins and other diet and everything. So they have been instructed to provide education regarding the vaccinations as well. So this is as per it's mandatory nowadays from American Diabetes Association guidelines. So that has been incorporated very recently.
Madhumita ma'am, you want to add something in this scenario, or everything is?
As a moderator, I'm going to put the question back. Okay.
You
So
are an expert
I want to give Tdap also, because pertussis also is something that I would think in an elderly, because we've had a lot of outbreaks of pertussis in elderly patients. Now I'm going to give her 4 vaccines. Do I give it on the same day, or can I give 2 vaccines today, 2 vaccines on the next day? Because she's still here, 2 weeks I have. Can I give 2 vaccines the next day? Exactly. So you have to give it on the same day, but you can give it also on the next day. But the only thing is, if you are giving a live vaccine as well as a killed vaccine, make sure that if you're giving 2 live vaccines, you have to give it on the same day. You can't give one, or 4 weeks apart.
None of them are live vaccines.
No.
So all these are inactivated vaccines, so you can give it on the next day also.
So let's proceed to the next case. 91 years old female, never smoker, BMI of 17, known case of hypertension on treatment. Patient also has scoliosis. She lives in Delhi with her caregivers. The patient was admitted with COPD and was discharged with acute exacerbation. After an acute exacerbation, she had pneumonia at that time of admission. Absolute eosinophil count was 410, IgE was 33. She was discharged 1 week ago. Now comes to the follow-up. She also has a osteoporosis on the DEXA scan of Tmax minus 0.49, which is significant. And FEV1 was 72% post-bronchodilator. She has never received any vaccine in last 50 years. So what vaccines can be given to this patient? The highlighting points are 91 years old age, COPD with acute exacerbation, and she was admitted with pneumonia, got discharged 1 week ago. She also has osteoporosis and no vaccination received till date. Ankit Sinha sir, we'd like to start from you.
Like she's 19 old and she doesn't receive any vaccinations. So I will advise her to take or like all the vaccinations, whatever can be given, because she has just have a pneumonia case and she's also a case of COPD. So definitely I will ask her to take influenza and pneumococcal vaccinations, particularly the conjugate vaccinations, and can offer all other vaccinations also for him.
So one question that comes to my mind is, can the patient be given vaccination during an exacerbation or maybe discharge, the time of discharge?
So it has mentioned, it already been discharged 1 week ago. So
Yeah.
I think it can be given. So at the time of discharge also, it can be given.
It's a question the patient asks, like, what is the utility of giving the vaccination at the 91 years of the age?
I like that question. So I was going to ask that question. 90 साल तक तो कुछ हुआ नहीं, तो why should I take a vaccine? Now, how do you deal with such? It's a vaccine hesitancy. So still at 90 years, it hasn't done anything to me. So why should I take a vaccine?
So we require only 2 vaccines then. The influenza and pneumonia, I think that should be sufficient without giving others.
No, I think she should take the vaccines. As with age, she has a higher risk of developing complications. She has multiple comorbidities. Therefore, it's very important that she understands that each of this adds on to her risk factor. And if you haven't had it for 90 years, it's not that you're not going to have it subsequently.
I have a question for you, sir. The last
patient had BMI 28, this patient has BMI 17, he is frail. Please, you should hold that also, very important.
Yeah.
इस patient में आपको जगह नहीं मिलने वाली जहाँ
Yeah. So my bad, I should be highlighting this BMI 17. But yes, all BMIs will be highlighted from next time.
There's only one very important point I want to raise. Never give any vaccines in the buttock area. They should always be given in the deltoid, whatever the vaccine or the anterior part of the thigh in young children. So please don't, because I see so many times rabies vaccine is given in the buttocks. Never give any vaccine. So if you have difficulty, you postpone by 1 or 2 days, because none of the vaccines are live vaccines. So you can give it in 4 successive days if she's willing, whatever. But don't give it anywhere else.
As a moderator, I will add some more thing. I don't know if you have this question subsequently, but 90 years, she was an aspirin. And will you give her vaccine? She's on aspirin. Ecosprin and clopilate. So that's a,
Yes, sir.
provider hesitancy. Many a times, we don't suggest, even if the patient wants, many of them don't suggest, saying that you are on, antiplatelets. I think this was one question during the COVID period, if you remember. I'm on antiplatelets, should I take the vaccine? So, yeah, so there is no contraindications to antiplatelets, but on the contrary, if you are on anticoagulants, yes, you cannot give an intramuscular injections. So what would you do at that time? What have you done in your practice?
I use the smallest needle possible, which is usually a 26G, and try to give it, don't try to go intramuscular. Most of these, though it is recommended that we give intramuscular, as I said, you weigh the pros and the cons. Even influenza vaccine, we give it more subcutaneous intramuscular, press it for a long time, usually nothing happens.
I think if you give a local compression, you're worried about the hematoma formation because of the patient being on anticoagulants, but it's not an absolute contraindication. And at 90 years, I would be scared of giving this patient aspirin because of chances of bleed happening.
No, all hypothetical. We need to discuss all that. Okay, another thing to add to this, in adults with a low BMI, can I give it in the anterolateral thigh like I do it in children? Yeah, you said not buttock, but yes, you can give it.
Anterior
yes,
thigh.
anterior.
So one more thing we are missing is osteoporosis, minus 4.9. We'll be giving denosumab. Is there any interaction of the vaccination with denosumab? Is there any role of spacing the vaccinations for that?
I'm not aware of any contraindication associated with that.
Yeah. Clonal, which there is no contraindication. That is what I remember.
And by giving the vaccine, even if she has osteoporosis, you're not going to fracture her or break her bones.
So this kind of situation comes very often, so it's now very clear. Sir, Chakravarti sir, you want to add something? No. All discussed. So now we move on to the third case. 44 years old, comes with the complaints of repeated hemoptysis. He works in a private factory in Delhi. He has a history of severe asthma. Also, HBsAg is positive in this patient. Absolute eosinophil count is 170. He is on high-dose ICS, LABA and LAMA in nebulization form. FEV1 is 42%. He took influenza shot in October 2024. Now, these are the highlighting points. BMI 16, DEXA minus 2.7, and all the chronic illness, severe asthma, on high-dose ICS, HBsAg positive, influenza vaccine taken in October 2024. So what vaccines can be given now? HBV DNA, I have to look into that. Yeah, that we will discuss that what else we need to take care when the HBsAg is positive.
She took influenza in 2024 and October.
October 2024, yeah, just 4 months ago. So that one question comes to my mind as we saw in Dr. Talwar sir's lecture, the two strains, SH or NH. So which strain that possibly the patient would have got, SH or NH?
So, as far as when that this time generally we get it the northern hemisphere strains, and in the month of April and all we can get it the southern hemisphere. But as Sarah also had told us that most of the time in Delhi NCR we have to take more of a SH strains, not only in Srinagar and all we have to take the NH strains.
Okay. I think the important thing is if you have a patient who comes to you, give the influenza shot, whatever is available at that point in time. If the patient came to me for the first time in October, November, I wouldn't wait till April to get the new SH shot. I would give the northern hemisphere and ask him to follow that cycle. I think that is what would be more feasible to do. But yes, if you have a patient who's coming to you, the southern hemisphere will cover the monsoon months. You need to have an annual vaccine shot following one cycle rather than creating a little bit of a confusion.
That's absolutely right. So it doesn't matter. I don't miss an opportunity to vaccinate a patient. And we've learned that viruses knows no border. So with the travel and, people moving from one country to the other, wherever they are, it's not going to see whether I'm in Delhi or whether I'm in Chennai or whether I am in Vellore. Whenever a patient comes, wherever he is, whatever is available, give him the vaccine. Now comes the question of, can I take 2 influenza vaccines in a year? I mean, in the summer months, I'm in Delhi and my job during the winter months are in Chennai where there is no winter, there is summer. So I'm always in summer. So can I take 2 influenza vaccines is the next question.
Yeah, so this is something which a lot of patients ask, and some physicians tell them that saal mein 2 dafa laga lo. So what is the opinion of the house? The recommendations are once a year.
Yeah, recommendations are once a year. So this patient, strictly speaking, doesn't need a shot now, strictly speaking. And he's not immunocompromised in the true sense. The antibody response for influenza has been shown that generally starts waning after 6 months. So for 6 months you are protected and then slowly it comes down, but after 1 year you need definitely a booster. So if the person is immunocompromised significantly, we can consider this double shot, especially if there is a risk otherwise. But routinely you don't need to give once a year is all that is required.
So as it is, the virus will keep on sort of having this antigenic drift. And there has been 1 year, I'm forgetting the year, which in that year the virus did not drift at all.
23 it was the same. 24
and
also it was the same.
There was data which was actually evaluated by the company itself, which they never published, which showed that even if you didn't take that shot on that year, your immunity continued. But WHO recommended that you should take the vaccine, even although there was less data to support a booster vaccine on an annual basis because the virus had not changed that much. So I think there is a little controversy about how long it should be there, but it should follow the once a year schedule.
And for this patient, I probably will give a hepatitis A vaccine also. If he has no antibodies to hepatitis A, I would prefer to give Hep A.
That was the only thing left to discuss, the HBsAg and hepatitis thing. Okay, now we move on to the next question. 44 years old male, never smoker, BMI 38, works in a factory. He is a known case of fibrotic ILD, which is severe. Routine blood tests are normal, but patient is on OCS 20 milligrams per day, Perfenadone, MMF 2 gram per day, and also on Bactrim DS every other day. FVC is 34%. He received pneumococcal 23 5 years ago. Now what to do? These are the highlighting points. Here I have highlighted the BMI, which is very high, 38. And the patient is on OCS, Perfenadone, MMF, immunosuppression is going on. Patient received pneumococcal vaccine, but 23 valent and 5 years ago. So what to do now, sir? Loveleen, sir.
So already patient is on OCS 20 milligram per day.
Yes, sir.
So do we need to decrease the amount of the OCS before giving any vaccination to this patient? And as per pulmonary point, is it really important, or patient may throw some exacerbations of the ILD per se? Another thing is, yes, we can maybe for some time we can decrease the OCS dose, and after that we can plan some vaccinations for this patient. Another thing which is important is patient has received pneumococcal 23 after 5 years. Now we can repeat a pneumococcal 23 dose also in this patient. Plus, patient has already received pneumococcal. We need to take the history again regarding the influenza vaccines also, flu shots. Because it must be there, the patient must have received the flu, because that is the most common vaccine which we are prescribing these days.
So,
one thing is I wanted to know that he has received pneumococcal 23. So, but that we had data that he has received conjugate vaccine or not.
No.
So now we can, like, after reducing the OCS dose, what we can do that we can offer him the dose of conjugate vaccine, because already 5 years, after 1 year of gap, we can offer the conjugate vaccination to the person who has received first the pneumococcal vaccinations. So after reducing a dose of OCS, we can offer him the dose of conjugate vaccine to him, and definitely the influenza vaccinations also.
So no matter what we do, since the patient is on immunosuppressive, the effectiveness of vaccines is going to come down, so by a significant amount. So, but the question here is, it will be a hard clinical decision whether to reduce the OCS dose and risk an exacerbation, or go ahead with the vaccination as described. And in my opinion, if the patient is at high risk of having an exacerbation of ILD, I would rather go with the usual vaccination program and accept a little bit of lower efficacy. And yes, a very good point that we will start again with Prevenar 13. We have no other choice. If you withdraw MMF, we'll probably have an acute exacerbation.
So I would like to hear from
that's a worse thing than, in my opinion. So I think it's a balancing act over here.
This is a perfect example of real life scenario. I always say that evidence doesn't make decisions, people do. So this situation where the 20 is the cutoff, he's on 20, so do we give? If you reduce it, you're going to have an exacerbation, what do you do? So at the end of the day, I think that you have to call the shots. Yes, if you cannot reduce it, go ahead, give the usual dose, perfectly true. 2, if you can optimize it by giving double dose, the current recommendation for people above the age of 65 is to give double dose. Even though this fellow is not above 65, but he's immunosuppressed, would a double dose of flu help? Probably. These are all out of, license recommendations.
Yeah, so I think there is a lot of issue that in older age group or immunocompromised patient, can you give a higher dose of the flu shot and will it actually have a more immunogenic response? The data, I'm not sure whether we have enough data to show that. There was a lot of push of giving a higher dose of the vaccine in older groups and in immunocompromised above 65, but the data did not really show that it led to more immune antibody production or a better immune response. That was also something that was debated a lot during the COVID-19 vaccine schedule. But I have another question. This patient, suppose the patient continues to take the polysaccharide vaccine. How often can you give the 5-year booster? If he starts at the age of 45, how often can you say, has he continued till the age of 65? What does the data suggest?
Okay. The basic tenets, always give the conjugate followed by polysaccharide. If you are not able to give the conjugate, you've given the polysaccharide, give a conjugate after 1 year. But then, how often, like you say, not more than 2 doses.
Correct.
Because so more than 2 doses, it is hypo-responsive. In fact, I don't even give 2 doses. 1 dose, if it's PCV 13, PPSV 25, after 23, after 1 year, I don't even give a booster after.
So this patient is 44 years old.
When he hits 65.
So you're not going to wait and give him every 5 years till he hits 65. There's no point. So after after 10 years, that's it. He doesn't need to take that's the point I was trying to make. Maximum 2 doses. There's no point giving it after that. That is what I'm trying to say. Even you don't have to wait till he reaches the age of 65.
And if you see pneumococcal vaccine recommendations, that's something which CDC in fact changed almost every year because they come up with new vaccines. So probably in a couple of years, even in India, you will have PCV 15 or 20. 15 is also, yeah,
20.
15
20
and
is now
20.
FDA approved.
Both would be available. So at that point, probably, in another 5 years or 6 years, I may give him PCV 20, and then with that, I would stop.
In this case, if you're going ahead with Hep B vaccination, this is a perfect case of measuring antibody titer after 2 months, because in this case, the response may not be that good.
So what about the other vaccines? He's young, he is 44 years. What about the other vaccines which we are not talking about?
Yeah, we are just
like
talking
typhoid
about the influenza, pneumonia.
What about typhoid vaccine?
Yeah, I want to hear from you, sir. What else can be given? Hepatitis, sir said he has added one. So we are talking about influenza.
Typhoid vaccine, hepatitis A vaccine.
HPV. What about HPV? He wants to know.
Not in his 44 years male.
Okay.
Typhoid is must. Typhoid, I think, is young,
Tdap.
44 years relatively.
I think typhoid is recommended if you have an outbreak. It's not to be given to everyone who is at risk. That is the current guideline. Of course, there is a physician discretion on how high risk of getting a typhoid it is, but if it is in and around an outbreak, you can give.
So we have to convince the patient to take the vaccination. So won't it be too much for that patient to know the bulk of vaccinations the patient has to take in form of all these things? So influenza and pneumonia will be the top priority, I think.
See.
No, I'm just asking, just taking an opinion.
Just like you treat children. Treat vaccination of adults just like you treat children. This is an ounce of prevention is better than a pound of treatment. Please, we must, all of us must go with the message that vaccination is important and we must immunize everyone possible.
He's a candidate for all killed and inactivated vaccine. The only thing is that I cannot give live vaccines. Had this patient been in United States, he would have even received Shingrix also, because he is an immunocompromised 18 to 50 years old. In India, we do not have currently the approval for below 50, but otherwise, even he would have received Shingrix had he been in US.
Okay.
So all kill vaccines allowed. No, I don't. I see a lot of immunocompromised, basically transplant patients. So if they are below 50, I don't give.
Currently, it's not approved by the...
Yeah.
Okay.
The licensing is not there.
So now we move on to the next case. We have 2 cases left. 62-year-old female, never smoker, BMI of 20, non-diabetic, lives in Delhi with 2 grandchildren, 3 and 6 years of age, admitted with MDA5 ILD with pneumomediastinum. So MDA5 was positive with high titer, received pulse methylprednisolone and rituximab on 0 and 2 weeks later. Discharged on high dose ICS, tacrolimus and MMF. Never received any vaccination in the past. There is history of herpes zoster 6 months ago. I think this was very well discussed in ma'am's slides, all these points. So we will be going through quickly with this, what else can we do and what should be given to this patient, and what's the spacing between the doses of injection in rituximab when the patient gets rituximab. Just kind of revision. Dr. Ankit Sinha will...
I will know if somebody heard
I remember the slides which said that if you want to give rituximab, I give it 4 weeks before or 5 months after.
Very clear message.
And
Sir. Very
this highly immunosuppressed patient, I don't think what the opinion of the house, if any vaccine can be given.
Madam said that 1 month before just that the next dose, we can offer him the vaccinations. And
it should have been 5 months past your last.
Yeah.
For Shingrix, that's the correct one.
That's true. So high dose ICS, maybe.
Again, if it's about 20 milligrams of prednisolone, I cannot give.
You cannot, I won't say you cannot give, you have to take a risk-benefit analysis, yes. So the immune response would be less, but so the issue, the debate that you would have is, would you deny the person a vaccine saying that you don't take it, considering that he will always require high-dose immunosuppressant, you would say that whatever benefit, even if it's small, it can give to you, I would go for it rather than not giving anything at all. But I do agree that your vaccine uptake or the immune response would be much less if you're giving high-dose steroids.
So now you want to add, sir?
Another thing which is important is like for herpes also, if you want to give Shingrix in this patient. So has
6
happened
months ago. So if the patient has got herpes 6 months ago, then
We have to wait, once the episode of herpes zoster, at least we have to wait for one.
So what does CDC say? No, even if you have had shingles, there is a recommendation to give Shingrix because 10% can have a recurrent disease. So if the person is at risk, which is this person is, and he can afford it, absolutely yes.
So I think the question is, how after Shingrix, after having herpes, when can you give the vaccine?
Earlier, the recommendation was 1 year, now 1 month.
1 month.
No, once you have recovered, in 1 month's time, if you're fine, you can take it.
So CDC says 1 month, but if you go to the website Shingrix, they say we make no recommendation, you can take it.
The company makes no recommendation, but CDC has now come down to 1 month. 1 year earlier.
It was 1 year, now it's 1 month.
so very clear message now. Now this is the last case, 54 years old male, never smoker, BMI of 21. The patient has chronic kidney disease, post-transplant. Lives nearby hospital and is on hemodialysis thrice a week since last 6 years. There is a recent catheter-related infection and was treated. The blood urea now is 166 and creatinine is 12.3. The patient was discharged and followed up at 2 weeks. Comes for the follow-up with hemodialysis due next day. The patient had pneumonia vaccine 8 years ago, but he exactly can't remember when he took it. So this is the scenario. We have some highlighting points. The patient is CKD on dialysis. So that question that comes to my mind is, do we need to enhance the dose or increase the frequency of the vaccination dose when the patient is on hemodialysis? That's the question generally people ask.
So there is no recommendation as such that once a patient is on hemodialysis, we have to increase the dose of vaccinations. The only thing was that the next question, like already he has received pneumonia vaccinations on a person who doesn't remember which vaccination he has received. So definitely again, now we can offer him the conjugate vaccinations. So we have to offer him the conjugate vaccination right now. And other vaccinations also we can offer him because he is already 50 years and CKD, he is a case of CKD, chronic kidney disease. So we can offer him other vaccinations also. Particularly for the pneumonia vaccinations, in this scenario, we have to offer him the conjugate vaccination.
Very high risk of having hepatitis B. So if there is no history, must be given Hep B. If there is history, you must measure the titers.
So the final take, sir, hemodialysis and vaccination.
Apart from hepatitis B vaccine, there is no recommendation for increased dose for any vaccine. Hepatitis B, I think automatically the nephrologist would have given him if he's on dialysis 0, 1, 2 and 12, 40 micrograms. So it's double dose for this thing at a higher frequency also. And apart from that, the other vaccines are just as usual. But because the person is immunocompromised, renal failure is an immunocompromising condition, the response probably will be suboptimal.
Okay. So I end my session with this question. Thank you so much for having a wonderful discussion on this stage. Thank you, everyone.
Can I have the panelists just sit down?
Okay.
Sorry. I think we had a lot of good discussion about certain vaccines, but as a moderator, I have a couple of questions more. I'm not standing between you and the dinner. I think I'm somebody who eats dinner on time, and it's already way past the dinner time. But 2 questions I will ask, and maybe I'll open the forum for others to ask. First thing is, if somebody has an egg allergy, can I give the flu vaccine?
Yes. So the recommendation is if patient had history of egg allergy and has minor reactions, you can go ahead and give the flu vaccine. If the patient has had severe reactions which included hospital admission, severe respiratory distress or some life-threatening disease, then you may like to avoid. If you agree, that's what I did.
The earlier recommendation was if he has anaphylaxis on eating raw egg, avoid. If he has, but if he has anaphylaxis, after raw you can give. It is only if it is after cooked egg, you shouldn't give. But currently, almost all the vaccines have such a inconsequential amount of egg protein that there is no contraindication. There are some vaccines which are egg-free also, cell culture derived vaccines, which are unfortunately not available in India.
So cell culture vaccine is the way forward, but they're not available. I think the other question that patients ask, actually, which I will try to reframe, is I'm a vegetarian.
Jain.
Yes,
I'm
exactly.
a Jain. I don't.
I will not. So why? Then what do you tell them about taking this vaccine which has egg in it? So this is something which is asked, this vaccine has egg in it, so I shall not take it. It's against my religion.
At the micronutrient level, the egg albumin or something else, actually it doesn't make a big difference. So it's your perception, that's it.
It's sometimes a lot of explanation has to be done for that.
Okay, your asthma patient develops ITP, which is non-responsive to corticosteroids, Azoran and everything, and you plan to do a splenectomy. What vaccines will you give? When will you give?
So, ma'am, again, because we are planning for splenectomy, we have to give pneumococcal vaccination, we have to give Haemophilus influenza vaccination, and we have to give meningococcal vaccinations. These are the 3 vaccinations we have to give. Generally, we give them 1 week before the splenectomy, but sometimes the patients, like a trauma patient, which comes to us and we have to do the splenectomy for them. So we can give after the operation, we can give within 2 weeks of the time.
Is there something that you would think while giving a conjugate pneumococcal vaccine and a meningococcal vaccine?
Preferably 2 weeks before or 2 weeks later, generally. And the recent recommendations say if you're giving it post and you have to give pneumococcal and meningococcal, don't give it on the same day, give it a month apart. So preferably give.
My question is that like sometimes we are not getting it is recommendation for Haemophilus influenzae, but we are not giving a single vaccination.
It's not available. So
it's not available.
Yeah, I don't give, sir.
The child vaccination, Pentavax.
So can we give that?
Yeah, so that has got basically diphtheria, tetanus pertussis, hepatitis B, and H influenza B. So it's a.
So Pentax vaccination.
You can give it.
So we can give them
You
the
can
offer.
Off license.
In adults also.
Yeah, because in India, your H influenza vaccine is not available separately. So you give it along with that. One last. One last. A 49-year-old, her daughter, who is 15 years old, has got chicken pox. Now, the 49-year-old mother has never had chicken pox in the past. Now, she's worried. She wants to take the vaccine. What would you give?
I had this case last week. Check a titer. So we checked for varicella antibodies. It was negative.
Then we can give her, sir.
Would you give chickenpox vaccine or would you give Shingrix vaccine? She's 49. Okay, this question came up. I think somebody answered. I don't see the gentleman now. What's the difference? Both are the same antigen, but the antigenic content of the Shingrix vaccine is almost 14 times more than this. And because of the absorbent which is used, the adjuvant which is used, the immune response of the Shingrix is several hundred times better. So at 49, even though it is not licensed, I gave that patient Shingrix vaccine.
So my pediatrician has asked that we are giving our children the varicella vaccinations very frequently, and it is in UIP and all. So once we keep giving the varicella vaccinations, do we require once my child will become 50-year-old, do we require that single vaccine that time or not?
Pneumococcal you're talking about?
No, Shingrix vaccine.
No, Shingrix vaccine, irrespective of whether the person has had chickenpox, has had the vaccine, at 50 you give Shingrix vaccine, above 50.
Okay, sir.
Without any difference.
Thank you. Thank you.
Thank you so much.
Thank you. We will
And,
close it.
This is time for the felicitation ceremony. So I request Dr. V. Ramasubramaniam to felicitate Dr. Randeep Guleria, sir. I request Dr. Talwar sir to felicitate Dr. V. Ramasubramaniam sir. I request Dr. Talwar to felicitate Dr. Madhumita also. So both of them came from Chennai. Thank you so much. And now I request Dr. Guleria sir to felicitate Dr. Vipul. Dr. Loveleen. Dr. Chakravarti. Dr. Loveleen. Dr. Loveleen. And Dr. Ankit Sinha. And I request Dr. Bharat Gopal sir, please be on the stage. So, sir, one more to Dr. Bharat Gopal sir. Yeah. I request Dr. Bharat Gopal sir, please be on the stage. And now I request Dr. Azmat Karim sir to be on the stage. Dr. Varun. Dr. Sandhya. Dr. Sandhya, please. And Dr. Siddharth Raj. Dr. Neha, please. Dr. Neha. So we'll give your original trophy in your clinic. We'll send. Thank you. So Dr. Vidushi, I think she left, sir. So now I request Dr. Sumit Mittal. Dr. Kanishk. So thank you everyone, and now we are closing this session, and please proceed for the dinner. We would like to thank our exclusive partners for this program also. Thank you so much.